All right, well, good morning, folks. Once again, this is for the NAU Center for Health Equity Research, Arizona Biomedical Research Center Education Series Conference about all of us. My name's Steve Palmer. I'm a professor in health sciences here at Northern Arizona University, and I appreciate you all completing that survey. These educational programs, as Cindy mentioned, are supported by the Arizona Biomedical Research Center, so please keep buying those lotto tickets. So this is the first of the 5 workshops we are hosting this year. The next one is actually it's on coordinating addiction services. And Dr. Jen Kahn, who's the CEO of Flagstaff Medical Services, has been taking the lead on coordinating that. And that will be on, let's see, February 28th at the 1899 Ballroom here in Flagstaff. After that, on March 2nd, we've got Dr. Joe Holechek, who is coordinating a conference on spatial modeling, which is for disease tracking and projection. So that will be on March 2nd. I'm sorry, not March 2nd, March 28th. Then April 14th and 15th, we're back to Yuma for our 7th annual workshop on border and rural health. And that will be April 14th to 15th with Miss Amanda Aguirre, who's a past state senator. And then today we're proud to offer this session, which is sharing research opportunities with the All of Us database. So Pam Buzzard, we're lucky to have Pam from NAU's Klein Library, has really taken the lead on putting this conference together today. So thanks for your work, Pam. I want to mention some acknowledgments here. Nick Beckett and Aaron, Nick's our right-hand guy. He's the one who takes care of all the details from ordering food to making sure all the tech works. So thank you, Nick. We have Cindy Beckett, who's part of the planning team as well. We have our volunteer, Erica, who's outside at the check-in desk. We have Beck in the back, who's going to be doing some marketing. And then I mentioned Aaron, who is the local tech support person here. So thank you all for this. And at this point, no sense wasting more time. I'm going to turn it over to Pam, our guru for the day. So thank you all for coming.
Thank you, Steve. So good morning. I hope that you all are as excited as I am to be here today. Feels like a long time coming, so I'm happy to be at the day. So I am, as Steve said, Pamela Buzzard. I'm the librarian for the College of Health and Human Services at NAU's Klein Library. And I thought I would just take a second to explain why the library is involved. In 2022, NIH reached out to us to ask if we would like to participate in a pilot study that they had using libraries across the country to market the researcher workbench from All of Us to researchers across campus. And they thought the library was a great way to reach researchers from all different disciplines. And we had quite a bit of training on the data in the researcher workbench, some R training and statistics, which was interesting and fun for somebody who doesn't have a coding or statistics background. But it was a really neat learning experience. And there's 3 of us at Klein Library who went through that. And while we do support students primarily, we are open to the public and available to anyone who would like to get some help. If you need help setting up your account in the researcher workbench and haven't done that yet, it is a little bit of a tedious process. We also we're able to purchase some presentation kits and to support researchers who might want to show the data that they use in their final projects. So it has a laptop, a projector, a mic, a clicker, and a few other components to help make presenting easier. And we also have some other electronic and print materials to sort of support research across campus. So even if you're not an NAU affiliate, you are welcome to reach out to us. And I believe that our contact info will be somewhere, likely in the resources that Nick is sharing. And there are a lot of multidisciplinary components to the data. You don't have to be working directly necessarily in like a biomedical field to be able to use it. There's a lot of social determinant data and Fitbit and other wearable data that's really interesting. And they've actually started including some data that involves children this year. So that wasn't previously available. So that will be really interesting as well. I'm going to let our next speaker, Jason Karnes, talk a little bit more about the content. But first, let me introduce him. I'm so excited that you're here, Jason. So thank you for coming. Dr. Karnes' primary area of research interest is cardiovascular and immune I should have read that word first. Pharmacogenomics, specifically investigating the utility of genetic polymorphisms to predict adverse drug reactions. He employs a translational approach to investigate pharmacogenomics associations using observational studies, functional genomic techniques, and eventually prospective clinical trials. His ultimate career goal is to facilitate personalized cardiovascular medicine and genotype-guided prescribing to avoid serious drug toxicities. Dr. Karnes also serves as the Director of Scientific Programs for the University of Arizona Banner All of Us Research Program. He is active in multiple professional societies, including the American Society for Clinical Pharmacology and Therapeutics, the American Heart Association, and the American College of Clinical Pharmacy. He's received support for his research from the American Heart Association, the Flynn Foundation, the American College of Clinical Pharmacy, and the NIH, including R1, R21, and K1 grants from the National Heart, Lung, and Blood Institute. Dr. Karnes currently serves as the John A. and Francis P. Ware Endowed Department Head for the Department of Pharmacy Practice and Science at the R. Ken Coit College of Pharmacy at University of Arizona. And there is a link in the bio to see more information about faculty and laboratory information from your department. So thank you so much. I'm so excited that you're here, and I'm going to hand it off to you.
Thank you for that marvelous introduction. It's a pleasure to be here at our neighbor to the north, Northern Arizona University. It is cold. My Diet Pepsi was frozen solid in my car this morning. I think I had registered 14 degrees, which, I mean, I thought it was cold in Tucson, but we don't get that low at this time of year. Happy to talk about the All of Us initiative. This research program is something near and dear to my heart and my lab. You know, as a genetic epidemiologist and a pharmacist, you know, precision medicine is really at the forefront of how we're thinking in terms of how we can transform healthcare. And you know, one of the key tenets here is diversity and including individuals that have been underrepresented in biomedical research up to this point. And that's really filling in a lot of the gaps. And it's not just about representation here. That's a piece, but this is really about good science. And I'll explain a little bit more about what I mean from that perspective. Great. So I typically present precision medicine in a kind of number needed to treat sort of example. So I'm a pharmacist, and you know, we use a lot of drugs in healthcare. So if we look at the left side of this diagram, this is essentially myocardial infarction risk individuals, right? People at risk for a heart attack. We have 100 individuals, and so let's say, for instance, there's a 40% MI risk in this group of individuals. So we have 40 people here that are colored in either red or yellow. The yellow ones are the people who, if this whole group of individuals got statins, their number needed to treat is a 10. And so if we gave everybody statins, those 10 individuals in yellow, they would have their heart attack prevented, which is awesome. And a number needed to treat of 10 is excellent from a clinical trials perspective. But we got these 30 other people that are going to get an MI anyway, right? They're unaffected by statin therapy in terms of clinical outcomes. And then we have all of these other folks, these other 60 individuals that are going to get this statin treatment, not necessarily benefit from it, not they're paying money for this prescription. They're potentially subject to adverse drug reactions. 3% of these people are going to be taken off of it because of adverse drug reactions. And so, you know, thinking about how we can better triage these patients, how we can identify who's going to benefit and who's not going to benefit so that we don't necessarily subject our patients to drug therapy if it's not absolutely necessary. And so, this is how I envision we're going to be moving away from this more traditional medicine approach. Not to knock randomized clinical trials, right? Obviously, randomized clinical trials are a big piece of epidemiologic evidence. We can establish causality, and we can be confident in terms of the effect of a drug versus a placebo. But we also look at averages, right? When we look at a placebo-controlled trial, we're looking at, on average, how do people benefit across this whole treated group? And there are going to be some people that don't benefit. There are going to be some people that benefit quite a bit. And then there are going to be people in the middle, right? But we treat them all the same. And from a pharma perspective, we try to give everyone a single dose. We try to give them the same drug. And we don't really talk about how we can fine-tune that approach. And so I'd like to get less of a fixed dose approach and this working on averages, this more traditional trial and error kind of medicine, into a more curated, triaged, precision approach, where we're taking all of the wealth of biological data that we can pull together now from the genome, from the transcriptome, from the metabolome, the metagenome, and be able to identify who can benefit most, who needs an alternative dose, who needs an alternative drug, and who's fine with the run-of-the-mill sort of fixed dose approach that the randomized controlled trials suggest. And really, I think all of us is one of the best ways that we can get there, right? This data, these approaches in terms of precision medicine require massive sample sizes, right? And so that's one of the first tenets here, is that 1 million or more individuals can be recruited for this effort. You could see it's all across the country. There's a number of health provider organizations and recruitment sites across the country, giving a fairly representative swath of participants across our country. The idea here is that people enroll, they allow access to their electronic health records, they provide genomic samples, but they're also recontactable. It's a longitudinal cohort where investigators, researchers can follow up with these consented participants, potentially down the road, ask them additional questions, have them participate in additional phenotyping and lab activities. And every year, they get more and more electronic health records data, and that gets uploaded, right? So that's one of the things that you have to keep in mind, is that there's a version released every year, and the following year, there are more participants added, but also existing participants get more data added from their electronic health record. That is the vision here, is that these are potentially recontactable individuals, although there isn't really a mechanism to recontact them at this point unless you have an NIH-funded ancillary study. There is a focus on engagement, but especially a focus on diversity. And so let me walk you through what a participant activities look like. And I think this is instructive in terms of where the data is coming from, but also what data are present within all of us, within the program. And so I'm a participant myself, so I can talk about this. My son is also a participant, and it starts with, of course, this consent and EHR authorization. Oftentimes we have recruitment vans outside of healthcare facilities, but you can also sign up and register your interest online. And so after you do that electronic health records authorization, there's also a genomic consent. You have an online interface where you're completing a number of different surveys. And so by far, the most comprehensive surveys are going to be the first 3, or what we call the core surveys. And they're the first 3 that are listed here. And the reason why this is important is because virtually all of the patients, or all of the participants within all of us, have filled out these 3 core surveys. Those 3 core surveys are required in order for you to receive reimbursement from the program. All of the subsequent surveys, which many of which have great data. There's a social determinants of health survey, right, which is really critical for many of the questions we ask. The problem is the respondent rate is relatively low compared to these initial 3 surveys. So you have a participant will go to a visit. They'll get their physical measurements taken, including blood pressure, height, weight, BMI, through a standardized protocol. They'll get biosamples, including blood, sometimes saliva, which is used for genomics. Typically, saliva is taken when blood can't be taken for various reasons. And then there's a urine sample as well. And so virtually every participant has these samples available in a biobank at the Mayo Clinic. All right, and these are the samples that gets used for the genomic whole genome sequencing, for the arrays, and then down the line, there'll be standardized assays as the program accepts proposals for what to do with these biosamples. In addition, you can either upload or connect your Fitbit, Apple Health Kit, your wearables data, right? And so there's a subset of these patients that have fairly robust wearables data. And you know, researchers have already used this. There was a Nature Medicine paper that looked at step counts and how those associate with protection from different diseases. And so this is already being used, but it isn't a subset. Like, not everybody who participates is wearing a Fitbit, or they haven't all uploaded this data. And so you have to be cognizant of that as you're approaching the data. So this is what you get in the current protocol. And this really represents the primary areas from which you're drawing data. So there are the surveys, right? So participant provided data, very important, right? Because you need participant perceptions of their race and ethnicity. You need them to report things like, the medicines that they're on. You need them to report past medical history, family history. That's the kind of things that the surveys cover. There's standardized physical measurements, right? So everybody in all of us should have a height, a weight, a BMI, a hip circumference in a standardized way, right? So it's not necessarily coming from EHR. That EHR data is another main source of data. Then there's the wearables and the Fitbit, and then there's genomics, which is based on, you know, the biosamples. And the goal is for every participant to have a whole genome. There's a short read whole genome on 250,000 participants right now, and there are arrays on over 400,000, and that number is only going to increase when the next version of the data are available. So the participant has access to this website. This is where they fill out those additional surveys, but as I sort of intimated before, these 3 surveys are generally very well filled out by the individuals in terms of a response rate, but participants don't always log back in and engage with the program by filling out these additional surveys, and so there is a fair drop-off there. There's a particular consent for a return of genomics results. I'll go through a little bit of what that means. There's a number of different ways that not only genomics is determined for research purposes, but it is also a return of result for the participant. So there are pharmacogenomic results that get returned. There's also hereditary disease risk results that get returned. There's a number of engagement genetics. This is sort of like the recreational genetics that you might see in an Ancestry.com or a 23andMe. There's ancestry estimates that are given, cilantro preferences, lactose intolerance, earlobe attachment, widow's peak, that sort of thing, right? So not a lot of clinical implications there, but it's one way that the program returns value to participants. And that's a big piece of the engagement part is, you know, the vision is not just let's grab your data, let's, you know, helicopter into your site and then leave with all your biosamples. It's more of the intention is more of a consistent community engagement where there's a clear return of value to the actual participants and the communities that they're in. I mentioned hereditary disease risk. So this is a process by which, through the whole genome sequencing, if a known variant is found that has clinical implications for Mendelian disease, we will report that back to the participant. It gets verified by a second sequence, but then the participant may be contacted. So if they have a BRCA1 or a BRCA2 mutation, potentially they're not aware of this. And this is something that affects up to 2% of individuals. Another thing is this medicine in your DNA report, which is pharmacogenomics. It's how genetics affects drug response. The interesting thing here is that almost 96% of people are expected to have some variant that affects their drug therapy, their pharmacology, right? And so although hereditary disease risk is going to be much more clinically impactful for a patient, presumably, it affects a relatively small number. Whereas the pharmacogenomics, the implications of which are dependent on actual treatment with these drugs, it is going to affect a much larger portion of the population. Here's an example of the genetic ancestry results. Looking at this, this is sort of a, these are getting a little bit more specific, but this is not a very specific result. This is an example, right? So if you compare this to, say, a 23andMe or Ancestry.com, they're much more conservative in terms of their estimates of ancestry based on your genome. Here are some of those non-health traits: the bitter taste perception, the earwax type, right? Some of this recreational genomics that, again, is part of the return of value to these participants. And then again, there's this hereditary disease risk report. And so this is what it looks like is, these patients or these participants will get a message after this variant has been identified and after it has been resequenced for confirmation. Then a participant, they reach out to a participant. Now, there is a genetic counseling service that is offered in order to help participants navigate this, to help them find providers and to assist them with the clinical care that is going to be necessary for these when these mutations are found. Here's an example of the medicine in your DNA report. So if you're not familiar with some of the pharmacogenomic examples, these genes over here, including CYP2C19, are drug metabolizing genes and transporters, right? And so when there is a genetic variant that affects function of these metabolizing enzymes, then often that can affect how drugs are metabolized and thereby whether you are getting a response from the drug. And so in this instance, somebody who's a star 2 for 2C19 is considered a poor metabolizer, and so clopidogrel or Plavix would be recommended against, based on current guidelines. And this is one of the examples that I mentioned where potentially up to 96% of patients carry some variant that affects pharmacology, some actionable clinical variant that will affect your ability to metabolize a drug or transport a drug or affect adverse drug reactions. So this is where we are now in terms of the actual enrollment. You can see the little blip there with COVID, of course. COVID affected everything. But in terms of recruitment, you're looking at nearly 600,000 individuals who have completed the initial steps of the program and over 800,000 who have actually consented. Of note, Arizona is the leading recruiter, and there's more people from Arizona in this data set than there are from any other state. And so that is a feature of the recruitment success from Banner and the University of Arizona. California is high on that list too. But there is a consortium across California of multiple institutions that are recruiting. But you also have to keep in mind, the image I showed before with all of these different sites across the country. We're a far cry from a socialized healthcare system here, right? Every health system is going to have a different way of recording this electronic health records data. They're going to have different policies, different protocols, different clinical cultures across all of these sites, not to mention differences in environment, differences in environmental exposures. It runs the gambit, right? And you have to keep that in mind. And I'll present a little bit more about the clinical site later on. It's it's always in the back of our minds in terms of how is site affecting this? How is the different health system affecting the data? In terms of just a reporter bias, ICD-9 and 10 codes, certain codes may be used more heavily in certain sites than other sites. That creates discrepancies across these different sites. It creates potential confounders in terms of disease or lab value associations. And so we need to account for this. And unfortunately, there's not great ways to do this right now. And we need to sort of wait until those tools are available and the participant numbers get even more robust. I mentioned diversity, and I'll mention it again in the afternoon talk, but that's one of the core features here is, non-white individuals are underrepresented in medical research. And this is a problem from a representation perspective, but I mean, this is a genetic approach, right? We're trying to capture variation across a broader swath of the population. The issue is that the vast majority of people across the world are not of European ancestry. Almost all of the biological data we have are people that are of European ancestry. And when you consider that the majority of genomic variability is outside of that group, even for genetic studies, we should be looking outside of that group. It's just bad science to focus on a single population where most of the genetic variability is outside of that population, right? And so this is really a scientific consideration in terms of representation of these different groups. But it doesn't stop at self-reported race and ethnicity. There's also gender identity, incorporating the self-perceived gender identities of participants that have been underrepresented in biomedical research. This includes age. This includes people in rural settings, right? I mean, these are also people that are underrepresented in biomedical research. And so how does a rural setting affect healthcare, access to healthcare? And there are surveys that go over this aspect as well. So here's a little bit more about those underrepresented. Income is another area. Education is another area. These are all underrepresented categories of individuals in biomedical research. And so the consortium has established it as a priority to increase representation among these groups and make sure that we're identifying the clinical effects of being in these underrepresented groups. Again, think randomized control trials. Very, very specific inclusion and exclusion criteria. You're getting a very uniform and homogeneous patient population that's often more affluent, often at a certain education level, often of a certain race, ethnicity. And so our clinical studies aren't necessarily representative of the US population at large, right? And that's one of the reasons that our disparities in healthcare continue to persist. So I've mentioned this a couple of times. Here are some of the numbers though. So you got over 400,000 with survey responses, over 330,000 with physical measurements, over 312,000 with genotyping arrays, almost 250,000 with whole genome sequences. Structural variant data, there's long read sequences, Fitbit records, electronic health records. And so, these numbers are massive, right? They're very big numbers, but you have to know that they're also this Venn diagram, right? So the 245,000 people with whole genome sequences, for instance, they don't entirely overlap with everybody that has electronic health records. So if you want to do a project that has genomics and electronic health records, then you have to be looking at the union of those two data types, and it's going to hurt your overall sample size if you design a study. And so each time you incorporate a different data type, there's this Venn diagram, and you're reducing your sample size for the number of individuals that have usable data in all of those different data dimensions. The hope is that you have enough people overall to where that's not a problem. But you have to keep that in mind as well. You can't assume that everybody who has survey responses also has Fitbit records, right? Or vice versa. Here are the surveys that I've mentioned a couple of times. Again, the first three are the ones that have very good response rates. Then there's ones that may have more interest to you in your particular research. Healthcare access and utilization, right? If you're interested in rural health and access to care, this is a good survey. Social determinants of health, right? If you're worried about perceived racism and how that affects clinical care, this is a good survey to look into. But you can also see that the response rate is not as high for those other core surveys. And so you have to keep that in mind so if you want to use SDOH data survey, then your sample size is going to decrease as a result, just because of the response rate. Here's a little bit about the access. All of Us has a public tier, and I'll show that in just a minute. If you're unfamiliar with All of Us, if you want to see whether or not it's relevant to your research, start with the public tier. You don't need access. You don't need to go through all the rigmarole, no DURAs, no education, no nothing like that. You just go to the website and you start searching. And then there's the registered tier, which I don't typically recommend people get access to the registered tier because the control tier has more data and it's just a little bit of additional training. Many institutions only have DURAs for the registered tier though. But for instance, genomic data is only available in the controlled tier. It's not available in the registered tier, and there's a number of other variables in the registered tier that are generalized. They're not as specific as they are within the controlled tier. This is that data browser, the public-facing one that I was talking about. The URL is up top. You can literally go in and do keyword searches just like it was a Google search engine. You can do them within each of these EHR domains. You can do them within the survey questions. You can get copies, PDFs downloaded of what the actual survey questions were, because obviously how the question is written has major implications for what the responses are going to be. But if you're interested in diabetes or you're interested in HbA1c, you can look up how many individuals have that lab within this data set. And you can start to gain a feasibility very quickly of whatever your research approach may be. If you're interested in sickle cell anemia, right? You can take a look and see how many people have been diagnosed with sickle cell anemia, or if you're interested in a particular lab value, et cetera, right? And you can even look specific SNPs up, single nucleotide polymorphisms. You can look up genetic variants and see what their frequencies are across the different ancestry groups that are in this data. So this is a great place to start. You can even write a grant with preliminary data based on what's in the data browser. You can't do association analysis. You can just pull numbers, but short of getting row level data and doing association, the public browser will enable it. Just keep in mind, again, new data are regularly added to the workbench. So there'll be more whole genome sequences when the version 8 of the data are launched. There'll be more electronic health records, not just for new participants, but for the existing participants as well. Hopefully they'll have an additional year or more worth of electronic health record data, creating an even more robust resource as they work through the data harmonization. Here's a QR code and also the URL if you want to register. People have had trouble in the past registering. Things like a state-issued ID will make this a lot easier, right? We've had a number of instances where people have trouble getting on. That's typically when they don't have a state-issued ID, like a driver's license. But many of those kinks have been worked out. You do need to have a DURA at your institution, and you can look that up online, whether your institution has one. You register, you verify your identity, and then you complete the training and sign the user code of conduct. Everything is through Google Cloud Compute, right? So Gmail accounts, Google accounts, those those become relevant again because you have, say, like a separate Gmail registration and login than you do for your personal accounts. Now you have an All of Us researcher account as well, and you just have to manage that and expect that there's going to be maybe some confusion if you're logged in under your other Gmail account, since Google is so pervasively used these days. And again, to that point earlier, look at all of the different consortium members. Each one of these different sites will recruit participants, and from different areas in the country and at different rates. Some of these groups have only recruited a handful of patients. Some have recruited over 80,000, right? But you could just see, again, the systematic differences that are likely to occur between these different health systems that are recruiting participants across the country. And we have to always keep this in mind. Now, that, of course, offers new opportunities to study the differences across these health systems. But don't look at this as like the UK Biobank, where there's a nationalized health system and everybody's data is getting uploaded and recorded in a similar way. We also have to consider that these systems are typically built for billing and not necessarily for clinical research, and always keep that in mind. Again, the partner network, the community engagement is a big piece of this, and there's a number of different community engagement partners that have been leveraged to help increase the comfort of individuals with giving their genomic data to the federal government. I mean, there's a lot of reticence around that point alone. And so, that community engagement piece is certainly a big part of all of us. And I just want to acknowledge the funding and our grant support, and of course the participants of the All of Us research program. That's the data overview, but I'm happy to answer questions, even if it relates more specifically to your research. If I don't have the answers now, I can typically get them maybe even before the session this afternoon. But thank you for your attention. I really appreciate it.
I have a question. Thanks for that presentation. It's great to see this. I'm just curious, what are the efforts to recruit additional providers or healthcare agencies to actually recruit? And are there things, because I believe we've got a number of providers here or folks associated with NIH here in the audience. Any ways we can, what are the efforts there? Any ideas for how we can get more folks to recruit participants?
Yeah, so the participants have been recruited through established recruitment partners at the moment, right? And so these are large awards that are typically given out to health provider organizations that have the infrastructure and have shown that they can recruit these participants. There are RFAs that come out periodically for new engagement centers. And because of the current state of the program, I don't think those RFAs are currently active. And so I believe probably here within the next year or two, we're going to see more of those participant recruitment RFAs coming back out. But I think for the moment, they're more or less static in who they're using to recruit. Now, that being said, there's no reason that you can't engage with an existing recruitment partner and see what options exist there. I mean, there are engagement partners across the state and across the country, and I can talk to our participant recruitment side about what the possibilities may be for getting involved from that perspective. But naturally, I mean, you think like this, there's massive electronic health records uploads that are part of this. There's participant consent and infrastructure, and there's a lot of regulatory hurdles that have to be addressed before new partners come on. That's one of the main issues, is that health systems aren't always willing or are very concerned when we're talking about uploading entire electronic health records for participants into a central resource.
Yeah, thanks, Dr. Karnes. That's a nice presentation. I'm just curious about I saw the last few slides, the logos.
Mhm.
I was looking for any tribal nations logo on there. I saw the Cherokee logo somewhere on
And
the
the
middle the other one, go back. Down at the bottom, right down the middle.
okay.
FQHCs, federally qualified health centers.
Mm-hmm.
I'm just curious, like tribal nations, when it comes to genetic research, um, I think most tribes are a little suspicious of such activities, and I don't know, in among those consortium members, I don't know if do you have any other, maybe just Cherokee, but other tribal nations a part of that consortium?
Oh, well, and I mean, we don't have to sugarcoat it, right?
Yeah,
Uh, there's a history of atrocities
Yeah.
with the American Indian and Alaskan Native communities, especially as it relates to the federal government, right?
yeah,
And so many of these communities are, and I think rightly so, very skeptical about participating in this kind of consortium. And there is an intense effort on the part of the consortium to engage tribal health and engage these communities and potentially to come to agreements with certain tribal communities about recruiting their tribal members and about coming to agreements with these tribal communities. Up to this point, no tribes have signed on to that to be able to recruit on tribal lands, right? And I think it's largely due to some of the skepticism that you're alluding to, especially when it comes to genomic research, right? I mean, this is the state where the Havasupai tribe, had their consent used for research that caused tribal harm, right? And so, to my knowledge, there's still a moratorium on genomic research within the Navajo Nation. And so,
Yeah.
it's of particular interest here. And I am involved in a demonstration project looking at some of the tribal data, but the V7 version has nobody who reported race and ethnicity as American Indian or Alaskan Native is available in the version of the data currently. And part of the reason is if an individual who self-reports as American Indian wants to participate in the program, all of us isn't going to deny that, right? They don't have a right to refuse that individual. But at the same time, if that's a tribally affiliated individual, then there's problems around tribal data sovereignty and that how that conflicts with the autonomy of the individual, right? So I think to answer your question from a basic perspective, no, there aren't any tribal affiliation agreements with all of us. There has been a lot of effort put into establishing those agreements, but up to this point, the federal nature of the program, the high amount of genomic sequencing, and then the potential that it's a very open program in terms of data, right? There are heavy restrictions on the security of the data, but once a researcher agrees, they can get in. And so there's a lot of tribal concerns with genomics around blood quanta and tribal affiliation. There's concerns around contradicting tribal origin stories, right? And so it's a very difficult to navigate issue, especially for a tribal community who doesn't necessarily see a direct benefit or value to their tribal population.
Yeah.
So it's a very interesting issue, and all of us has taken it very seriously. But up to this point, the concerns have sort of outweighed that willingness to participate.
Yeah. No, I appreciate the response. I think I'm Navajo, and I serve on the Navajo IRB, the Tribal IRB Research Board, and so there's ongoing discussions, as you said, with our tribe about amending our genetic research moratorium and to lift it a bit to allow other genetic related research can be done or conducted among our people for certain, genetic diseases that could, to benefit our people.
Oh, sure. Yeah.
yeah.
And there's many ways in which you could envision a direct benefit coming from the genetic research. But historically, that hasn't happened,
Yeah.
right? So how do you ensure that as a tribal community, how do you codify that in an agreement, before allowing researchers to come and acquire biosamples and genetic material from your members,
Yeah.
right? And it's difficult, but I think you're right. There need to be guardrails. There need to be specific aspects to the agreement that protect some of those interests, including a return on value. What happens to these biosamples, right? Different tribes have different cultural beliefs, right? But a ceremony for those biosamples or a return of those biosamples to the individual, upon their death. These are additional stipulations that are difficult to navigate within the consortium as it's currently set up, right? So there's lots of potential issues there.
Thank you.
Sure. Anything? Oh, yes, please.
I'll just yell. Oh, there it is. Okay, now I won't yell. Well, along those same lines, I think people might have concerns about the ACA being repealed. And so like thinking back to the days when insurance companies can deny people for pre-existing conditions, and I also see that there is privacy and security later. So if we're going to talk about that, then that's fine. But I guess I was just wondering about if someone gets a notification then that they have this genetic mutation or something like that, and how that could potentially affect their insurance coverage. And so I was wondering if you could talk a little bit about that.
So there is GINA, right? So we have some protections on a federal standpoint for insurance coverage based on genetic results. But there are gaps within GINA. So disability insurance, life insurance, right? Those aren't part of the GINA law. From a privacy perspective, I think that's one of the things that all of us has done very well, because having everything located on a central repository, right, where there's access restrictions and administrative control by the consortium, creates an environment where you can't download the row level data, right? And there are a lot of restrictions on what you can do with that data. So it's quite well protected from like a physical protection of the data type of standpoint, which is distinct from programs like UK Biobank, right, where historically you propose a project, you download the data to your local servers, and that's where it sits. And so there's a lot of genomic data from the UK Biobank that just essentially sits on institutional servers, and they're changing their model to be more of a central repository, right? The other thing is that all participants are protected by a certificate of confidentiality, right, through an NIH government-funded research, and so privacy is protected in that way too. Even if subpoenaed, the consortium doesn't have to give out the genomic data, and so they're protected from that aspect as well. That being said, giving genetic data to the government is probably the main concern that we hear in terms of reticence for recruitment. And there's all these direct-to-consumer companies now, 23andMe among them, right? And there's some sharing with GlaxoSmithKline, right? That wasn't necessarily a part of the original agreements when people were signing up for this. And that 23andMe issue has brought this largely to the forefront. And I think that's the main concern around participants, is how well are their data protected. From a scientific perspective, I think that's part of what they do really well, because I think they understand that, you know, any breach of like data security breach is a disaster to the program, right? And they've done everything they can to prevent that. Does that sort of address your question? You know, there are things that we're doing very well from a privacy and a security perspective, but it still remains at top of mind for all the participants. If they have issues with consenting, that's typically the one that we hear most often.
My mic. Oh, there we go. My question is more technical. So you mentioned like, so does an organization that is recruiting participants, then the All of Us consortium can pull information from that electronic medical record. Does it matter what is the platform of that EMR? Because there's all different kinds, and we get criticized all the time for the one we use because it's very clunky and difficult, and yeah.
Well, I mean, yeah, and I mentioned we're not, you know, in a socialized healthcare system, right? So we have Epic, we have Cerner, we have homegrown systems across the country. And so what there is there's been a lot of development in, you know, the past decade for something called, you know, OMOP, which is the, you know, the standardized discrete variables within an electronic health record. So it's a way of standardizing those across systems, right? So that's a good thing, right? Because we can sort of harmonize the data across all of these systems. But that being said, there are still issues in terms of trying to join all of these systems together, right? And so there are variables that get that don't end up getting uploaded because they don't have discrete fields within the OMOP structures, right? And the OMOP is being consistently updated and upgraded on a regular basis, right? So there's a, you know, it's a sort of a moving target from that perspective as well. Maybe like 10 years ago, we probably wouldn't have been able to do this just because of that standardized structure, you know, it didn't exist. Strides have been made in the EHR to address that, not the least of which, you know, they've been led by sort of the DRC at Vanderbilt University, who up until a few years ago had their own homegrown system in terms of EHR. So that is addressed, but at the same time, you always have to remain cognizant of how the EHRs from one system and another system are being joined together and aligned, and what are the potential points of data that you're missing, or the biases and the confounding that gets incorporated as a result. And I should say, you know, all of us doesn't have constant access to the existing EHR data. What happens is they package up that data for the existing participants for these curated data repository updates, and they send the data to that secure system where it gets de-identified then. So that's another point I should mention, is everything here is de-identified. So there are no references to names, even 5-digit zip codes are suppressed. And so those privacy considerations, the methodology there is fairly strong. That being said, there may be ways to access identifiable data down the line in a more supervised, IRB approved kind of approach. But yeah, all the data here are de-identified. I mean, there's genomic data, right? So how de-identifiable is genomic data really? But at least our current regulatory environment, it's not considered PHI.
Now, I could just imagine a lot of missing data due to some EMRs being, you know, just not compatible.
And that's, you know, that's a feature of EHR research in general. Before I ever got into this, I was doing electronic health records research. And you're right, there's you don't get the same lab value on every single patient that comes into the clinic. And so there's a lot of missingness, and you have to deal with that when you're trying to do a research study in EHR data. The nice thing is is that you have such massive numbers that you hope that that noise to signal ratio just improves. Just based on the fact that you have so many individuals. Yes, you're going to lose 70% of your population because they didn't get an HbA1c test or whatever it was. Hopefully that's not 70%, right? But that's a bad example. But you can see.
Find in the EMR because it's like a little note or something.
Well,
Yeah.
another thing to note here is that free text notes are not available. You can't ensure the de-identification of those free text notes for a system like this.
Right.
Again, they may be available in the future under an IRB approved, more structured research protocol, but you can't get free text notes. So if you're planning on doing like natural language processing or, AI on free text, that's not going to be available at this time.
Thank you. Thanks.
Sure. Okay.
I'm going to just say at this point, let's take a 10-minute break. We'll reconvene in here at a quarter after. And then we are excited. We have some time right before lunch for an open discussion about research ideas and potential collaboration to see also who is doing things. So let's take a little break and then we'll see you back here in about 10 minutes. Thank you, Dr. Karnes.
Thank you so much. I am really excited to have another colleague of ours from across the state here, and I get to introduce Dr. Susan Holechek, who is an assistant teaching professor at the School of Life Sciences at Arizona State University with an affiliated appointment at the Simon A. Levin Mathematical Modeling and Science Center. Following her undergraduate degree, she worked at the Molecular Biology Division of the Peruvian NIH, studying dengue, and was part of the response team for the first dengue outbreak with hemorrhagic cases in 2000. Her graduate research at Arizona State University involved the study of vaccinia virus pathogenesis, and her postdoctoral research was focused on the role of the immune system in the modulation and transmission of infectious diseases using both experimental and mathematical modeling approaches. Her current research is at the intersection of population genetics and chronic diseases. Dr. Holechek has received numerous grants to expand her students' research opportunities and has been honored with the Pat Tillman Veterans Center Honor Roll Award, Outstanding Faculty Mentor, the College of Liberal Arts and Sciences Outstanding Instructor Award, and most recently with the Catalyst Award by the Arizona State University Committee for Campus Inclusion and the School of Life Sciences Teaching Excellence and Innovation Award. She's currently the director of the School of Life Sciences Undergraduate Research Program and lead ambassador for the All of Us Research Program at ASU. Dr. Holechek also facilitates and promotes undergraduate research opportunities for both in-person and online students at Arizona State University. Thank you so much.
Thank you so much. I wish I would be there with you sharing, this talk, but thank you so much for the introduction and thank you so much for the invitation as well. And I would like to talk to you about some of the lessons learned when using the All of Us research program in the classroom. But before we get started, I'm glad that Jason has kindly introduced the program to all of you. Just as a reminder, our mission is a little bit broad, but it's in charge of nurturing the partnerships, delivering also one of the largest and richest biomedical data sets, and also to catalyze an ecosystem of communities, researchers, and funders who can use the All of Us research program. As it was mentioned before, we have a lot of different type of data that could be used for our researchers. And in this case, I'm just going to provide some of the examples of how the students can use this data from All of Us. We also discussed earlier the different type of tiers. The public can access the public tier. This is through the data browser, so there is no specifics needed. You don't need a DUR agreement for this. So it's a nice way to get the public familiar with the research database. If you want to be a researcher, we have to go into the researcher workbench and use either the register tier and the control tier. It was mentioned earlier that the control tier will give us more access, not only to all the different like surveys and electronic health records that are available in this registered tier, but also to the whole genome sequence data as well. Now, for both of these, for both the register and control tier, the organization requires a DURA agreement with all of us. And there's also some ancillary studies that are around the US with different studies, for example, as nutrition. We're also starting with gathering some data in minors as well. So little by little, we hope that in the future, we get more type of data that will facilitate and help us understand other research concerns that we have in other populations as well. So we have a lot of different researchers across the US and beyond, over 13,000 that have been registered, many academic institutions, including our universities here in Arizona. We have also some non-for-profit organizations that are part of this research as well, and healthcare institutions. If we want to look into the different type of projects, all of us is going to let us also take a closer look into the type of projects, who are the researchers, what are the objectives of that research that are going to be, followed, and they are showcased as is part of the agreements that we have to have once we become researchers in the database. We also have what we call researcher engagement partners. And I just wanted to bring this slide here because you notice here ASU, we are a SAT awardee from the National Alliance for Hispanic Health. We started actually as being partners for engagement, and now we are also expanding the role, kind of looking into facilitating enrollment as well from participants. So just to give you an overview, many of you are familiar with Arizona State University. So we have 4 different campuses in Phoenix. We also have a virtual campus of ASU Online. We have a large population of online students, a lot of enrollment. So it's making us one of the largest universities in the US. And I just wanted to put this slide here so you have a context into why we're doing what we're doing and how we're using the All of Us database for this purpose. So with so many students on campus, just to put this into perspective, the College of Liberal Arts and Sciences is the largest college at ASU, and the largest unit of this college is the School of Life Sciences, to which I belong to. And in the School of Life Sciences, as right now, we have the number of our online students has surpassed the number of our in-person students. So it kind of makes sense that part of what I want to communicate to you today is geared also to how can we, participate with these students and make them part of this process as well. So our students are very diverse. I love this picture because they look very happy. It looks like a sunny day. Right now it's kind of cold outside, but we have a very diverse population. We also attract a lot of international students to ASU. And I teach a lot of classes. I've been at ASU for a long time, and I discovered that one of my passions is teaching. So I always talk to the students during office hours, even in-person students, online students, and they have a lot of questions. One of them is, how can I be successful in my classes? What opportunities are there for undergraduate research? And how do I get involved in community service and volunteer? So these are kind of the 3 main questions that they have every time I see them. And, it's like I always try to take how we can, as faculty, try to accommodate, try to answer these questions in order to better serve our students. So it was mentioned before that I'm the director for the School of Life Sciences undergraduate research programs, and I try to see SOLUR as kind of research opportunities for all the students at the School of Life Sciences. We also welcome students from different schools, as I started partnerships, for example, with the School of Molecular Sciences. So we welcome students that are studying biochemistry, for example. They can also be part of the program. And the SOLUR program is host at the School of Life Sciences at Arizona State University. And I wanted to just very briefly tell you a little bit about this program. This program is designed to promote opportunities for undergraduates so they can participate in research. And these undergraduates are already in a lab. They work with faculty or other mentors. This could be postdocs. This could be senior grad students. And there is a lot of benefits for these students who are part of the program. We teach them about scientific communication and research, some transferable skills as well, like how to, for example, go to an interview and, showcase their skills. We have also modules for career development and help them, understand where do they want to go after they graduate. We also work with their mentors. We really would like our students who are part of a lab to have a really good relationship with the mentors. And also, professionalization of lab work, so how to prepare them for grad school or med school, because we have a lot of our students in the school who are very interested in med school, so it's a large percentage of them who are pre-med. And what you see here at the bottom is kind of the pathway that these students will follow. As soon as they're in a lab, they will become apprentices, then they can go into the researchers, and then once they are researchers, they could apply for to become a scholar or fellows. Both these positions, they come with a stipend, kind of like to help the students, for some hours of work at their lab, helping their PI. But what was the problem about the model? The model in Solary was that we already had to have these undergraduates in a lab. But what about my students who are just entering, the school? They are transferring from community colleges, and they don't know, what is or what are the steps to become a successful undergraduate researchers. So with that objective, I created this class. This is what Bio 194, we call it iSTEM Solar Prep. And it was created to prepare students to become successful candidates when applying to any research lab of their choice. Over the time, it has also gained a lot of track with undergraduates from other disciplines. So these are not just biology undergraduates. We have even students from business, engineering, nursing that they take the class. It's only 1 credit. And we want to create a community that is going to be supportive for them. We want them to be interested in research, to learn, scientific skills. So we have lab components for this class. And above all, we want them to be competitive applicants for STEM. So our curriculum has core biological concepts. We have lab techniques. We teach them how to write a resume, how to send cold emails to faculty. We have also introduction to programming as well as group research projects. And this is how we tied this component for all of us. So here's just some pictures. We use active learning classrooms where students are going to be working in groups. They are they form a group that are going to use the group for the research projects. We also have them being part of a labs. And I always like when I turn around and I want to snap a picture and they're all happy. So that's the purpose. Again, these students are not in a lab yet. They're just learning, from week 1, what is a scientific method, how to write a research question, how to formulate a hypothesis. And we are going to, help them with this. So we use the All of Us research program as part of the curriculum for this class. They're going to be working in groups. And, each group is going to be working with a particular disease. We provide a list. We have 10 groups. There are 10 diseases that they can work with. And they are going to be formulating a research question about that disease. And we take them through a journey through different drafts until the final project in which they can use the All of Us research program in order to gather data and present at the end of the semester. So we talk to them about what is All of Us, because many of them they have not heard about it. So we are telling them, about the program, how this program aims to improve the healthcare through research. And that is also a very unique database in the sense that it's going to have thousands of health conditions that affect the US population. So We talk to them about the program. We do a brief introduction so they know what it's about. And now they become researchers through the series of trainings I know that Jason was explaining early on in the talk. So how can we use this for research? For example, if they're interested in the prevalence of cardiovascular disease, as a researcher, they could access the surveys, they could quantify the data that's stored in the system, they can research journals, they can look into electronic health records, they can formulate a hypothesis, they can discover novel treatment and techniques, and publish their research. So those last two will be kind of towards the end. And some of our students, they will continue their journey, and they also will be using the All of Us database for the grad school as well. Another type of information that it was mentioned earlier is the surveys. So what if a research question will be if our students are interested in cross-cultural perceptions of illness and they would like to collaborate, they can also access surveys, they can access research journals and data that is obtained from other collaborators, they can network, and this is a really nice feature of all of us, is that you can actually network with faculty or colleagues from other institutions and, work in a big project together. You can formulate a joint hypothesis with them, and, hopefully with the end goal would be to publish your results in a journal. So everything starts with building a cohort. I know that you have more talks later that may guide you a little bit through the process, but everything started with building the cohort. We provide the students with the appropriate videos, and training and how to do this one step at a time, as we have, some programming as part of this particular class, which is Bio 194. So again, we guide them step by step throughout their project. And while we give them just the general, you see the topic of the disease, they have to generate their own research questions. So every semester, each group will come with their own research questions based on the literature search that they do at the beginning of the semester. And this is just a couple of our students. So they are presenting the data. We invite them, the best groups, they're invited to our symposiums, and they successfully, they have obtained several prizes. They can work alone, they can work as a group. Sometimes the students from a group, they decide to take their project to the next level, and they present, during our conferences. We have a couple of the conferences that are offered for free in the School of Life Sciences. So they become presenters and participants, and, we print the poster for them. And it's very nice to see how the students that, they're just starting the STEM journey at ASU, they're able to, present the results from their research. And what is nice about this class is that I always have the collaboration of undergraduates. These are undergraduates from my lab and from different labs that come back because they understand the importance of helping the next generation of students. So these are students that went from ATAs to instructional A's, and they are all part of a research lab and working on their own research project. They were Bio 194 students themselves, and it's kind of demonstration of the success that we have with this class. And I'm very, very glad that they kindly volunteer their time, to come back. This picture is, I think, a year old. Some of them already entered to med school, or they're having their interview for a PhD school this weekend. So I'm very happy for them and, and the support that they have provided to our class. And then this is the big question. I always call this is the $1 million question. What about online students? Online students, I teach genetics online. It's a very large class. We have between 250 to 450 students based on the semester. And these are classes that are 7.5 weeks at a time. In the summer, they're shorter. And, I always have these questions for them, what would you like to gain from the class? Are you interested in research? Would you come to campus to learn some techniques? And the reason why I ask my students these questions is because I really want to understand them first. And there's a lot of concepts in genetics. They're sometimes very hard to grasp without having the hands-on component. So based on their answers, and it was always, yes, we will go, yes, we will go. So I decided to take upon myself and created what I call the Research Immersion Week for online students. And this is just an example. Every semester we change the topic. For this particular semester, we were looking into cell biology techniques, molecular biology techniques, on immunology as well. And you can see in the map there at the bottom, they came even from different parts of Europe. Now, I only have a very small space, only for 16 students, but they are always happy. And they, you know, some of them, I call them the repeat offenders because they would like to come back, and they come back. And now this particular Research Immersion Week, which started as a pilot that I decided to do this last semester, this last fall, was our 10th time doing it. So I'm very, very happy. And we are planning already the one in the spring. So some of the things that they did in that particular cohort, again, you have the students involved, and the beauty of the online students is that, you know, they range from ages. You can have, I think the average age for an online student is about 32 years old. And they're coming again from different parts of the US and different parts of the world. This picture is very dear to me because this is my pilot. I didn't know, you know, I knew there was interest. I didn't know they were coming. You know, now we know in advance if they're coming. We have like a group meet that we can, you know, we can check on everybody, what time they're arriving, etc. But it was great to see my first cohort, and you have my 2 grad students that decided to wear black that day. They're like flanking, and they both graduated. They're both working now. I have other grad students, but again, this is like a team effort. It's not just me, and I'm very thankful for my team to provide these opportunities to the online students here at ASU. Something that I wanted to highlight, so I mentioned now how we promote and how we use the all of us in the Bio 194 class. Why do we care about our online students? How we provide some opportunities for them to come to campus. And now I want to mention, you know, how these students, both online and in person, can go from students to researchers. So bear with me for a second. I know the list is long, but you know, we mentioned about introducing the All of Us research program in the classroom. We do this as well with the online classes. We use the Research Hub to demonstrate the major components, so we guide them through the whole process on how to set up their cohorts, etc. We incorporated the use of All of Us into graded group projects. So my Bio 194 students, there are no exams in that class, so the group project is a very, very important aspect of their grade. For my online students, because we have many, many more, we're in the hundreds, so those group projects are going to be as bonus points, you know, so because I understand that they're, you know, they're working, so they may not have a lot of time to dedicate to the project, so they're offered there as a bonus opportunity. And the highly motivated students, they're invited and they're welcome to expand the group research projects. They can join Solar. Also, we provide training in R and Python for our junior researchers. We advertise the All of Us office hours. We recommend those for our more advanced students. And we have a series of deliverables, and mostly this is going to be the abstract submission to the SOLS Undergraduate Research Symposium, as well as the Bioscience Southwest Symposium. These both conferences are free, and I'm always very happy because as part of the All of Us family, we have partnership with Banner and U of A, and we always have representatives coming there, you know, to these conferences and help us as well as judges. So if you're interested, please let me know. My email is going to be at the end. It's a very rewarding experience for our undergraduate students. So the program will pay for printing their poster, and the more advanced students, so those who have continued their research journey with their project, and you know they have extra research questions and they have been working really hard, they are welcome to submit their abstracts to other conferences like SACNAS, ABRCONS, ASBMB, and they have successfully obtained travel grants and support through the SOLUR program, the Hours programs, or GSG at ASU. So this All of Us integration in research, we have used this, as I mentioned before, in Bio 194. Bio340 general genetics. We also use it for our honors genetics students. So we actually have a class later today with them, and they also work in groups. For them, it's not a bonus for them. They have to work. And use the database for the research project. And so far, we have over 400 researchers. I think last time I talked to somebody from the NIH in a panel, and they mentioned that ASU has over 1,000. So I don't know. I want to be more conservative with my numbers. We have 30 and above research posters that have been presented since we use the All of Us database, and was very glad to see the kids. I call them kids, but they're my students, winning 25 awards so far and counting. So hopefully, we're going to get more of these students presented the research for the upcoming symposium in April. And, again, looking forward to see them, how they're using the database for their research. And here's some snack peeks for our online students. You can see them in the bottom left. They present, we have iPads for them. We print their posters, they present their research, they talk to the judges. And, every student, because now we have a large online population, our conferences are hybrid. So the students will present their posters, both in this setting, if you're an online student, and there is another section where they can go online and present it, like in a Zoom or Gather Town, for example. These are some pictures from students to researchers. I'm really glad that, this research was be able to be presented at Discover BNB in San Antonio. And we have a multidisciplinary team there from the 3 researchers that you see here on the left. On the right, Hector, he is an online student, just graduated, and also an ambassador. So we have a lot of our students who are also All of Us ambassadors, and they're gladly, they make the trip, to come to campus to present their research. So I'm going to highlight, and I'm watching my time because I don't want to go over time, but I just wanted to highlight some of the type of research that these students are doing. This is research from Anania colleague, and she was looking into flaviviruses and host genetic interactions, and looking into the All of Us database. She can look, what is happening with the flavivirus, and what can we do with respect to, what information we can gather from that. Anania is currently a PhD student in genetics in Cornell, but this was one of her side projects in her last year as a senior undergraduate. The program, and something that's very, very important, and I think you're going to learn later on, is how to build your cohort. You have to have good information about what's the research question that you want to address, what type of conditions you're analyzing. So if we're talking about flaviviruses, for example, you have dengue, Zika, West Nile yellow fever, etc. What type of lab and measurements can you obtain from the database? And then, what type of survey responses you want to capture in order to answer these questions. She was very into the bioinformatics, so she did a lot of work with the cohorts, and there's a lot of different techniques that she employed in order to, find any indications about a particular mutation in the Fc gamma receptor that is involved in what we call antibody-dependent enhancement. So we know that happens in dengue, and she wanted to see if this is possible, or if there is a way to capture this when we look into the difference in the SNPs in patients, and if they have dengue or other or were afflicted by other flaviviruses. So some of her results, again, this is work in progress for her. I told her, that to continue her research. I know she's very busy with her PhD, but she did a really nice, these are all the figures that she created. Again, she was very passionate about bioinformatics, and she have a lot of background on that. And she was able to compare, you know, if you can tell here in this picture, all of us present were. So she was comparing her data to previous data from another article and see how that matched or not, you know, because sometimes times in science to what was previously reported, and looking into the different SNPs into both symptomatic and also controlled patients. So that's one example. Another example of another research project. This is Gerardo and Romel, and I really wanted to highlight this to students. Gerardo is still with me. He's a senior undergraduate, and he's one of our instructional aides that helps with teaching R and Python to our students in Bio 194. And he's also very kind because he supports the online students that have all of us projects once they come to campus. Romel is coming to ASU this weekend. He have already several interviews at different universities, so he's applying for his PhD. Gerardo is starting his master's in the fall. And I just wanted to mention, you know, that these students using the All of Us database has helped them, you know, in their journey, especially when they're looking into interdisciplinary collaborations. Gerardo is a data scientist, Romel is a biochem. So both of them, you know, have a really wonderful idea. And this is talking about hypertension, you know, going back with discussions with Romel, you know, it's like, you know, we both, because I was in the same boat, you know, our parents have suffered from hypertension, you know, we're talking about the different drugs that are taking and how sometimes those are not effective. So that's how this project started, and looking into some potential polymorphisms in this particular gene that could lead to different response to amlodipine, which is one of the most common drugs used for hypertension. So they look into different SNPs, into the different genotypes, and the association, you know, that these particular individuals with this genotype will have with a decreased or increased response to this particular drug. So they build the cohort, you know, looking into the conditions, looking into the medications, looking into the different SNPs that went into the different counts, etc. And they took all these results to look into some preliminary information about what's happening in different populations. And, you know, when looking into the different allele counts, they realized that it was a particular population that is, you know, was considered, according to the database, like the African origin, that would be more predisposed, you know, to have more counts of the mutation. So, you know, uninformed data or could be given to them, given that, you know, they will have the mutations that will prevent for this medicine to be effective. Another example, this is Lucy. Lucy took, she was in, I recall, group 1 in my Bio 194 class. That was the best group that semester. And she wanted to continue her research project. This is now looking into dengue and at the intersection of climate change and also the polymorphisms. And she did a really good job. She got to win the e-poster for ABRCOMS in the spring session. So she got the outstanding award. She was invited with a travel grant to ABRCOMS. And, you know, I love this picture because this is her, you know, presenting her research. And she was able to do something very interesting. So she was using both All of Us data as well as, you know, climate data in order to create, you know, this graph. So very, very interesting. So, you know, you can do that as well. You can, I know we have a lot of information of All of Us, but we can join forces with others as well. Very briefly, and keep watching my my clock here. So this is another example that from one of the grants that was given to us by the Healthy Americas Research Consortium. These are grants that are 6 months. And this was an interdisciplinary approach to examine obesity epidemic in the Hispanic community. So a very, very large group. Here we have students, grad students from up to 5 different labs. So it's not just my undergraduates and my grad students working on it. So we have a great representation, everybody here coming with their own expertise and interest. And it was a very good experience for me, you know, to manage such a large group and being then in different, from different disciplines and in different labs. You know, obesity is very important. You know, the rates are about 40% for adults. Severe obesity, 1 into 10 women are more affected, and, you know, 1 in 5 children are obese. So, and over 45% of the prevalence will be in underrepresented groups. So the stats are not very good out there. And, you know, our research wanted to look into this project approach. So very similar, you know, the first step is, okay, who are we going to include in the cohort? You know, how we're going to work in the researcher workbench? What variables are we looking at? And for this, because we have the expertise from different fields, you know, everybody proposed, you know, different markers that are related to obesity, and they are very relevant for this project. So we also look into 2 types of comorbidities, type 2 diabetes and cardiovascular disease. We also explore the socioeconomic factors, which, you know, we can have that type of information in all of us as well. And, you know, when to study the frequency of the BMI groups, first we divide this in like healthy, pre-obese, and obese. And we observe that for the Hispanic population, it have a stronger skew towards the obese BMIs. We look into the comorbidities. Again, this is the frequency of the cardiovascular disease by cohort. So this was associated with higher BMI in both populations. So we observed that there is an increase of cardiovascular disease. You know, the higher BMI is present. We also look into the type 2 diabetes. We have also saw a very similar correlation. So there is a trend, you know, patients with are in the obesity category will have more frequency of type 2 diabetes in those cohorts. And when studying the SNP frequency in the Hispanic population, so we both for Hispanic males and Hispanic females by BMI category, and you notice that in the graph in the left, you know, there is a differences between the Hispanic healthy and the obese. But when we look into the Hispanic female, you know, there's no obvious changes or obvious differences between the frequency of these alleles in those populations. So we're looking into further into just comparing the Hispanic males and the non-Hispanic males by category. This is where we found something very interesting, that these differences were, you know, this difference were observed just in the Hispanic male, you know, comparing the healthy versus the obese. And the allele frequency in the non-Hispanics, there was not obvious differences between them. So yes, for both the IL-6 SNPs as well as the FTO gene. For the female populations, there was not significantly difference in the frequency in both the Hispanic females and non-Hispanic females in any of the categories. And this is what is led us to, okay, future, more work has to be done. Again, you know, these grants are only 6 months. So we need to look into, okay, what's happening, because as I mentioned before, obesity, you know, affects more the women. So no differences in IL-6 of FTO in any of the categories between Hispanic females and non-Hispanic females. Another aspect that we look into were the social determinants. So this is healthcare access. And, you know, in this, what we observed is that the Hispanic populations are more likely to lack healthcare than non-Hispanic populations. We also look into the education level. And we observed that the obesity rates are going to decrease as the education levels increase. And, you know, those participants who were college graduates and those with advanced degrees have the lowest prevalence of obesity. So what else can we do? I just wanted to mention some of these examples of, you know, what the students, you know, grad students and faculty can do as a project, we're using all of us, but what else can we do? And at ASU, it was mentioned before, I'm the lead ambassador. So we have students that are researchers. They, that's how they start the exposure to all of us. They become ambassadors, and some of them as well will become all of us scholars, in the sense that they are part of that group, which is a nice cohort of students and faculty that will work together through a very extensive period of time in a particular project. So I really like these dynamics because it allows our ambassadors in the middle to talk about their research to the public. So in a sense, we're doing knowledge mobilization. They're all involved in an all of us project, so they can talk about the results to the public. So we have a very great, I love the kids. This is an ASU outreach team, 26 all of us ambassadors at ASU. We have done 16 classroom presentations, 15 community events, 7 tabling events, a research conference, and reaching out to over 2,000 potential participants. And this is where the collaboration with Banner and U of A is very important, because once we have establish this relationship with the potential participants, we partner with Banner and U of A. Maybe some of them will want to proceed and go through all the consent process, and provide their samples as well to be part of the database. So a lot of community engagement. These are the Mill Avenue, the second Sunday events. We go and we do strawberries, DNA extraction from strawberries. We talk to the people. It was really cool, I remember last year. Again, we partner with the Chandler Innovation Fair. ASU Open Door is coming soon in February as well. So we have a lot of people coming. They're very interesting. It's a great way to interact with the community at large. More recently, we have the ASU block party. We also go to the retirement community. So we have a big group of ambassadors that are, again, they're also researchers, and they're willing to spread, the All of Us research program to the rest of the world, in a sense. So my overall conclusions, and I think we're great on time. We use the All of Us research database as a valuable resource, so we can integrate that in using real world data into STEM education. We can do group projects and data analysis. Online students can also participate through collaborative projects, and we provide remote support for them. We also, help the students with training in R and Python and advanced programming courses. We suggest where they can go for that. Research engagement is going to be fostered through abstract submissions, local conference presentations, and they also have access to national research symposiums. Knowledge mobilizations by students and researchers and ambassadors. So they have this dual role. They're doing the research, and they also are ambassadors for the program, and providing that information to the public. And all this highlights how the impact of this that all of us will have for STEM education. And hopefully for those of you in the audience that are teaching classes, you could, you're more than welcome to use all of us. Students are very happy both in person and online. I see a lot of these applications for schools, and students say, my first research experience was using the All of Us research database. So it's very nice to see that, and how they take advantage of the database, and they are very invested in their projects as well. So with that, I would like to acknowledge our participants, the All of Us Research Program, the National Alliance for Hispanic Health, the Healthy America Foundation, School of Life Science, the Solar Program, the Hours Program, and the WESO Program, for their support to our students. And, I will take any questions that you may have. I have here my email address. If you want to contact me, please do. I'm always looking for judges for the poster competition. So I would love to have some of you there. You can come to Tempe campus as well. You can do this virtually or in person. And, I know this was shown before, but if you want to become a researcher, please register and follow the steps. Again, it takes time, and the research integrity training is actually very, very valuable. I just have to renew my annual one every year. You have to renew it, but it's very important, and it helps us understand how to take care of the data, how to respectfully, write a research question, how do we interpret that, etc. So you have a really, really good suit modules when you go through the training that you have to pass. If not, you can do the quiz, I think, again the same day. If not, you have to attend in 24 hours. So it's not just clicking. You as researchers, we actually have to understand how to, go into the database and how to use this properly. I'm a participant myself as well. So, my information is in the database as well. So I'm both a participant and a researcher. And, thank you so much again, to all of you for the invitation, and, the National Institute of Health and the All of Us research program. With that, I would take questions.
Susan, I'm happy to help facilitate the in-person questions here, pointing to folks. And I don't know if you can see the group or if you're just seeing me. So
I just seeing you.
Oh, hello. Do folks have questions for Susan?
Okay. I don't know if the mic works. Susan, thanks for the presentation. It's fascinating. I had not really, until your presentation, had really considered using the All of Us database for students to learn research, and then actually to come up with some tremendous findings and really jumpstart to, it looks like, tremendous careers. Can you talk through the timing of it and how long it takes for your students to, hey, is it a one semester class to get them started, or what's the time frame for your projects that you
Thank you. No, that's a great question, the timing. So for our Bio 194 students, for our honor students, they have the class for 16 weeks. So they have the whole semester to craft their project, and for the students in person, it's part of their grade. So the product is going to be a research poster that they will be presenting as a group. So that's part of the curriculum for those two classes. For my online students only have 7 weeks and a half or 6 weeks in the summer. And you'll be surprised the projects that they come with. The online students are fantastic. Again, they go all for it. They work even if they're in different time zones. So to answer your question, in-person students, they have 16 weeks. Online students between 6 weeks and 7.5 weeks. And in this period of time, they have to register, they have to go through the trainings, they have to formulate the research question, and we have checkpoints throughout the course. So there is a draft 1, there is a draft 2, and then the final project at the end. So it's not that, the end of the semester, give me your poster. That's not how it's gonna work. And we have also a very supportive community for the online students. A lot of them now, they're master students, and they volunteer their time in the weekends to have these pop-in resources and kind of like office hours where online students in the current cohort can ask questions about the project. They have done their own recordings as well, how to go through the database and how to set up the cohorts, etc. So we are building community. Students really like to work with the database, and that's what they decide to volunteer and help the next generation. And that is happening in all my classes. I always have kind of like an army of students, helping each other because they understand the benefit. And as I mentioned before, I'm very, very glad that all of them who have taken this to the next semester, they enter the SOLAR program, They are very successful. They're going into PhD school. There's even an NSF, grant for to help them with their research as PhD. So the sky is the limit in a sense. And, it's just motivating the students so they can understand the value of the use of the program. And they're very happy because they are ambassadors. They're also participants. So they are involved in different aspects with the program. And I think that's very valuable as well.
Thank you. What? Oh, no.
Hi, thank you so much. My question is there any component of this training that talks about the recruitment of the participants in the All of Us data set themselves? And second part of that question is, do the students ever become participants of the data set with their biometrics?
That's a great question. So when we introduce the All of Us program, we talk about what is, who are the participants, how the participants get involved in the database. So, the researchers understand where the data is coming from. A lot of our researchers become ambassadors. So then they go through the training on how to, kind of like advocate for the program. And, and currently we have some ambassadors that we call promoters who are also trained in, they're promoting enrollment as well. So again, for a class, if we're just talking about the students being researchers, they have an understanding of where the participants are coming from. They have to go through the training, right? Because the access to All of Us is individual. So they have to have a valid ID and they have to go through the over 2 hours of training in order to get access to the database. So they are very, very aware of, all of that. And then our ambassadors, those who, become ambassadors and they're part of the program, they are very familiar and they are trained on all the recruitment aspects for the populations. You mentioned also the participant question. Yes, at the end of the semester, once they have work and they are like almost done with their project, we have a special session in which we tell them, well, you become a researcher, now the value of this information, we welcome you to be a participant. So we have that in place as well. And that's why the partnership with U of A and Banner is very important for us because, we have them always in our research symposiums. And this is where the student, hey, we know that you're interested. There is going to be a table at the event. Please reach out to them. They will help you through the process. Hopefully that makes sense. But they're all aware of the, the different levels. I'm a participant, a researcher myself, and an ambassador. And we have a lot of our ambassadors who are also researchers and participants. They're all participants. All the ambassadors are participants in the program. And I think it helps being a participant because then you get an idea of the type of questions that are in the surveys and, help the students to plan accordingly the research projects as well.
Thank you so much.
You're welcome.
Did you have another question, Steve?
I just wanted to ask what tier data? They're not using just the public available. Are they using the students that are accessing the All of Us data? Are they down in the what is it, second tier? I can't recall
The control tier.
Yeah. Yes.
Yeah, so that's a great question. So for both classes, well, actually 3 classes, including the honors, they all have to have the control tier access. I mean, ASU has a DURA agreement, and that's what we can get access until that. We tell the students, especially the ones who are just starting, for first year students, is like, we do not expect that programming. So for those students who are just starting their journey at ASU, the projects are not going to go in depth into programming. The examples that I showed, like Romel and Gerardo and Anania, those are students who have bioinformatics background. So they can go into the depth of the project because they have the training in R and Python on how to do those things. So we're not telling the students you have to code. If you do not know how to code, you are not going to pass the class. We don't do that. We tell them this is a database. See how much, how far can you go? Let's take a look at your research question, and we guide them through the whole process. Some students, because the class welcomes students from all majors, sometimes we have students who are in bioinformatics, who are in engineering, and they go at the extra step. But we are not expecting them to do any programming or coding. We teach them how to do it, but it's not an expectation for the class. Hopefully that makes sense. Our grad students, once they take the classes, they would use all of us to continue their project, and now they're able to do those extractions. But we have the support if they want to go that extra mile. We have some recommendations of classes that they can take, and we have we have people, we have ambassadors who have an expertise in data science that could help, for example, the online students that want to go to get their master's degree and continue their project.
Thank you, Susan. I actually have a question, but only if there aren't others or any online. Okay. At NAU, as the librarians who have been sort of trying to work across campus to get engagement with the researcher workbench, we have sponsored, we have like an intern to scholars pairing, whereas an undergraduate researcher working with a faculty member and also like an undergraduate research course. But we're having a hard time getting faculty who understand how they would be able to use all of us in those pairings. And so I'm excited to share the recording of your presentation, but I was just wondering if you sort of experienced that, and also, how maybe you were able to sort of overcome it, or are you the sole instructor?
Oh, right now, for the classes that I mentioned, I'm the instructor, so I'm in charge of those classes because I designed by 194, and I decided to incorporate all of us into the genetics curriculum, both for honors and for the online. We have other faculty in other classes that are more advanced, like evolution, for example, and they are aware of the all of us, and they're planning on using all of us for their curriculum. So, which is very exciting, right? Because we meet with the faculty, we're having lunch, and I talk to them about the all of us, or they have heard from their new master students because they took one of my classes before, and they're very, very interesting because the potential, there's a lot of data out there, and it will be great for this type of more advanced classes, like for master students, PhD students, or those who are like into niche bioinformatics or evolution, for example. So I think there's at least 2 more faculty that are excited about it. Hopefully they'll do it. The challenge is if they're teaching online classes, they only have a very brief period of time. I don't know how my online students in genetics, they do it. I mean, again, you are welcome to come to the symposium on April 25th to see some examples of both the online students and the in-person. And I think, that's the best testimony to see what the students are capable to do with the database. But hopefully we have 2 more faculties, one in my department and the other one in another department that will be starting using all of us.
Thank you. I guess I'll have to make it down there in April.
You have to make it.
Recruit some faculty. Thank you.
No problem.
Are there any other questions? Well, thank you, Dr. Holechek. Again, this was really exciting for me to hear, and hopefully for everybody else. We do have a bit of an open discussion right now to hear how some folks have been using the researcher workbench, or potentially just, I don't know, opening up a discussion. I did have a couple of things I wanted to mention that popped into my head. and I hope that's okay. I did look, and ASU, NAU, and U of A all have DURAs that cover both the registered tier and the controlled tier. I looked for anything that had the name, the word Arizona or Flagstaff or Northern Arizona, which to see if there were any other organizations that I could at least find off the top of my head that had DURAs, and I didn't see any, but there is a way to get a different type of agreement as an individual if you aren't associated with an organization that has a DURA. But I think that that's a little different, and I don't know what that looks like. And I also wanted to just point out that Dr. Karnes and Dr. Holechek both thank the participants at the end, and that is one of the requirements of working with the All of Us data is recognizing the participants and like the vulnerability that's kind of involved with giving your data. And also when you upload your project to the researcher workbench to get access, you kind of describe what your project will look like. It does go into a public list, and participants are encouraged to look at those and you know, give positive or concerned feedback. I don't know that many do, but it is sort of like a feedback opportunity for participants. And then also, there's no obligation to be a participant with your health data in order to use the researcher workbench at all. There are different portals, and that's just a completely different opportunity. So I don't know if that question was going through anyone's head, but does anyone want to start? And maybe somebody who has done some other types of work. We saw a bunch of examples from Dr. Holechek about your experience.
Go ahead. How about this? Raise your hand if you used or accessed the All of Us data set. Who here has done it? I know, of course, Dr. Karnes has. Dr. Holechek has. Okay, so that's one thing to start with. So now, as you've seen this, who's got researcher lines of inquiry that you're looking at that you're like, I am interested in these areas, whether it's nutrition, there's going to be data in there. What about sharing some of your ideas for where this is what I might be interested in? And we have some experts here that might be able to point us in the direction of, yes, there are some things to look at, and this is an opportunity in using the data workbench. Is that a good way to start? Anybody want to share your research interests to begin with?
I'm wondering if the data includes information beyond demographics and biometrics. For example, I work on a project that involves incarcerated populations. Is there any sort of data that talks about like their history along their lifespan, or maybe even like occupational data?
I feel like and I see that you're thinking. That's your thinking face, I think. There, because it's a protected class, I mean, it would be hard to get some of that data. So I can't think of anything related to protected classes that I've seen. And then lifespan data, I don't know that any, well, I'm sure at some point participants have passed away who started it, but I don't know that there is lifespan data. I don't know if anyone else knows off the top.
Or even just to simplify that, just occupational information.
So I'm looking into the data browser now in terms of, you know, I'm going to search occupational in the search box and see what we come up with. So apparently there's some information in the healthcare utilization survey, but it's related to an occupational therapist, right? So it's apparently not what you're after. So I don't recall it. Now, they collect a lot of data in those surveys, and so I could be wrong about this. And certainly my area of interest is not necessarily in incarcerated populations. Now, Again, I'm not familiar with efforts to recruit those individuals. I mean, I think that, you know, based on the fact that they're a protected population may mean that they're underrepresented as well within this data set. I'd be surprised if that weren't the case, but again, I've not looked into this and I'm not an expert. I don't recall the surveys asking about occupational, I mean, certainly occupational status and potentially, you know, professional discipline, but in terms of a history, I don't think so. You know, there's a lot of gaps within these surveys in terms of, you know, not just, you know, questions that researchers would like to have answered. You know, we were talking about tribal populations earlier, and one of the frustrating things that we encounter is the fact that, you know, we have a self-report with regard to whether you identify as American Indian, but there's no question around tribal affiliation, right? And that's a key determinant in terms of, you know, how to identify those communities. But we don't have that, right? So just an example of where there are gaps. Now it's evolving, right? So they're always adding new surveys, they're always adding new questions. But, you know, also participants, you know, have lots of surveys to fill out, right? And so you wonder about the response rate, you wonder how completely these surveys are being filled out. And you also wonder about, you know, this is mostly a digital interface, right? And so we do have a mechanism for, and I say we, the consortium has a mechanism for paper surveys now, but at first that wasn't available. And there are lots of populations that have, you know, access barriers just to digital interfaces, whether that be, you know, the cost of data by their cell phone provider, the, you know, rural health and you know, internet access. And so you could see that creating barriers to the response rate as well. And I don't know that I'm providing a direct answer to your question, but these are certainly things to think about from a survey response perspective. I mean, there's lots of other types of data, but relevant to what you're talking about in terms of incarceration history, I don't think so. Mortality was brought up as well. So there is a newly funded, what's called CLAD, which is a data linkage through the University of Colorado. And their purview is to connect all of us with some of the additional external databases, things like Medicare claims databases, things like national death indexes, right? So that is coming as well. There are mortality reports within all of us, but they're not necessarily comprehensive. They're not like a structured national death index, you know, federally supported. That's going to be, you know, whenever, you know, the government knows about a death and you have a death certificate, you know, that's a portion of this. With all of us, it's more like if it's in the EHR, then now you know that that individual has passed away. But if they passed away in a different state or, you know, outside of that health system, it might not be reflected. And again, I'm talking, but that's another thing to keep in mind is that people get their care from all over the place. You know, you get your refill prescriptions from Walgreens or CVS, and so that's not going to be reflected in the EHR in the system that gets uploaded. So you have to consider that too. You may find, and I'll present a little data later, that, you know, a lot of people just have one instance, one visit in their EHR data because, I don't know, maybe they were visiting that city and then they enrolled, or they just go there for emergency room visits, right? And they don't necessarily get their chronic care for their chronic conditions at that same health system. So these are all things to consider when navigating the data.
Thank you.
Okay, thank you. So I have a couple of questions. This group right here, we're all public health people, and so we're really more interested in actually data collection instead of the, research projects. So I have a couple of questions related to that. First of all, is that an appropriate use for this database? Secondly, I was just curious what kind of behavioral information might be in the survey. So in particular for our programs, we oversee substance use prevention programs. And so is that kind of, are those kind of behaviors tracked in the surveys? I was also wondering what kind of mental health or behavioral health data might be collected. And then finally, whether or not it can be narrowed down into geographical areas. I understand that that would greatly reduce the number of people, but is that possible? Thank you.
I can answer some of them, but to clarify, your first question around appropriate use of data, what would you rephrase that?
Yeah, just in general data collection. So for instance, we might apply for a grant, or we might be reporting to our funders about the number of people in our county. One of the things we often use is different types of mortality, like Coconino County has high rates of such and such. So maybe disease, for instance, disease around alcohol-related liver disease, that would be one that we use sometimes. Cancer, perhaps. So those types of things, we might be collecting just that information for our county.
So, I mean, one of the questions that we often get in like reviewer comments for manuscripts is how representative is this population to the US population, right? And so I think you are the experts in terms of public health and what is an appropriate source of data. I can't speak to that necessarily. But because we have specific recruitment sites and specific health systems, you don't necessarily expect it to be reflective of, say, the state as a whole, right? And so I'm not sure that it would be an appropriate source of data unless provided, with the appropriate context around, this is from all of us. We can get representative figures, and these are the sites where these people are likely coming from. But the representativeness is a big question, and we've done a little bit of that work in comparison to U.S. Census figures, and it does seem to be somewhat representative. There was a healthy population bias that was very common within the UK Biobank. That doesn't seem to be the case with all of us. In fact, it does seem like all of us participants are a little, in general, sicker than the U.S. population in general. And I think that makes sense based on the recruitment strategy of going into inpatient hospitals and health provider organizations. These people are going to be seen often within these healthcare settings, and so they probably have a lot of chronic conditions. So you asked about geographics. Like right now, a 3-digit zip code is all that you can get. And so 5-digit zip codes, they're not available now. I don't think they're going to be available in the next releases, but I could be wrong about that. The geolocation stuff is very valuable to a number of different researchers, including environmental researchers. I mean, we get asked about that a lot. And especially if you're, public health people concerned with, what's going on in your state as opposed to everywhere else. It's difficult though because of the privacy methodology. The more information you give out from a geolocation perspective, the more likely it is that you're able to identify that person. So we have 3-digit zip codes at this point. Those can, and you can get that down to a state level. But anything more refined, more specific, especially as it relates to potentially tribal zip codes, I mean, those are all going to be masked. And I think you had 1 or 2 more questions. I'm not sure if I
was just asking about the behavioral health or mental health tracking.
Yeah, I mean, so I think Some of those questions are fairly well addressed using Likert score questions within the surveys. And you really have to sort of explore the surveys through the data browser to figure out whether the right questions have been asked for your particular research question. Otherwise, it's all EHR stuff, right? So if you're looking for HAM-D scores, then it needs to have been input as a discrete variable within the electronic health record and then survive that OMOP harmonization and then get into this de-identified data set. So if it's primarily represented in free text notes from physicians, like, I mean, that's my sense for a lot of the scores around mental illness, then it may well not be there as a discrete, like a lab value is what I mean by something discrete, a lab value or a measurement. But free text notes haven't been made, are not in the data set. And again, that's a reflection of the balance between privacy and then the data that they're making available.
Are any of those questions in the surveys that you know of?
I believe there are some.
Okay.
The surveys again are done at a given time point, right? Participants can update their surveys, but you're not getting like repeated sampling, longitudinal, progression of depression scores, for instance. There are a couple of questions that look at mental illness. I think they're more directed at presence of mental illness or history of mental illness than they are about evaluation of severity, or probably more of the useful information that you'd want as a researcher. So I think it's on a case-by-case basis. You may find that there's useful information there for depression, but if it's a less common psychiatric or mental illness, then you may not get very much out of the survey data.
And Jason, I can jump on that one too. So I'm here. So that's a very interesting question. I'm glad that we have, a group of you who are interested in public health. I mean, I started the NIH in Peru, so I know how you feel. You want all this information. So a couple things. Jason's right. There's a lot of questions about behavioral that are going to be present in the survey. My best advice is for you guys to become participants. It's very simple, just become participants. And that's what I always encourage my students as well. By going through all the surveys, by all the questions, then you know exactly how to use that information in your own research. Because as a participant, you know exactly, oh, they asked me about this type of behavioral. They asked me about like, how many drinks do I have? How often? It's like they ask about childhood trauma and what type of that could be. So it goes into a lot of detail. Just to go through all the surveys, it takes time. But I highly recommend, if you're interested in that you become participants yourself. So then you can kind of gather kind of a list of, oh, okay, I remember they asked about this. They asked about alcohol. They asked about childhood events that may have contributed to depression, or they may have contributed some sort of mental issues. So that is very well explained. All of us, we have these really nice videos that tells you about the program, and and anytime you can decide, okay, I don't want to be a participant anymore, or I don't want to share this. So it's going to be up to you how much information you provide to the system. But from the public health perspective, it is very, very comprehensive. I remember I started signing as a participant, and then I couldn't finish all the surveys, and then I log in again, on a Sunday where I have more time and to provide more information. So all those questions are there, and those are going to be captured once you want to develop a project that is interested in maybe, mental health issues in adults, and how is that related to potential childhood trauma. I don't know, just an example. So there's a lot of things out there. So highly, highly recommend that you become a participant to have a better overview of all those questions.
I am pretty confident that I'm sorry, that those main 3 surveys, and I know the social determinants survey, if you just Google the All of Us, data browser. That's the like public tier of the data, and all of the questions are listed there that are in the survey. I haven't looked at other ones, but I know that I have for certain seen those on the public tier. And so you can get an idea of what's in there as well.
Yeah, all of the surveys are available as PDFs on the public data browser. They can be cumbersome to look through, right? But they're there. Yeah.
Do the databases include Alzheimer dementia data?
Yes.
So, yeah. Susan, you want to take this one?
Oh, yeah. So I think we're going to have the same answer. Yes, they do. They have Alzheimer, dementia, schizophrenia, and it's all going to depend also the codes. And that's when some research about, how that's coded in the system is important. You can look for Alzheimer in the database, and it's going to tell you all the related codes that you can use, especially if you're going to do a little bit of programming and how to kind of like call for the data in the system. You can look also into SNPs associated, like for Alzheimer, you can look into ApoE SNPs as well. So there's a lot of information about Alzheimer, dementia, schizophrenia, a lot of mental illnesses as well.
So I can add to that too. And this is, I think, illustrative of, some phenotype specific concerns researchers may come into. And right, so Alzheimer's is distinct because it's a disease that happens later in life. It's difficult to diagnose, definitively diagnose. You can't do that until after they've passed away, right? So you have to think about this in terms of, the EHR and the billing system, and when do these codes get input for a particular patient, right? And so there's a lot of misclassification associated with ICD-9 and 10 codes. So a dementia diagnosis, an Alzheimer's disease diagnosis can be not necessarily representative of the real clinical context. So you always have to consider that. The odds ratios that you see for ApoE, relative to a well-controlled, cadaver-confirmed Alzheimer's disease cohort are far reduced. They're much lower odds ratios, right? So it's dirty. The data is dirty. You also got to consider the fact that the average age is around 40, right, for the participants that are currently in. Many of them have lived long lives, but many of the participants don't have sufficient data or lifetime really to be considered controls or to be considered not having Alzheimer's disease, right? So that's something distinct for Alzheimer's that you might not encounter with other diagnoses, but there are data and there's a lot of good work that can be done, but the EHR data are fairly messy when it comes to diagnoses, especially when it's hard to diagnose at the bedside,
Thank you.
I have a question. This is kind of, sorry if I missed this earlier. With the data, when somebody signs up and actually is enrolled, are there historical records automatically accessible into the system, or is it from that point moving forward, or is it only?
Yeah, as long as it's within the same health system, all historical records for that individual get uploaded. So you have some people, and I have a slide on this. There's some people that have 50 years worth of EHR data uploaded into this system. Yeah.
I was curious, Dr. Karnes, if you know that with the project coming out of Colorado to pull in other data sets, is there like look into the VA type of data or their EHR, I guess?
That I don't know specifically whether, the VA system is a part of, as a federal health system. I think there have been discussions about how that, even the Million Veterans program could be leveraged towards all of us, but I don't think there's any official relationship. I could be wrong about that, and I'm not sure whether the CLAD award incorporated any VA data. To my knowledge, I typically see, the Million Veterans Program as a completely separate, cohort in terms of all of us. Is, you have to have an affiliation with the VA in order to get access to that data. It's a similar data set. It's mostly male, but it's fairly diverse as well. And they have, a standardized EHR system. So that's helpful from their perspective. Also, they get most of their prescription refills from the same place. They're not necessarily going to a Walgreens and CVS. So there's a lot of advantages of that data set. But to my knowledge, there's not a collaboration or union that's official between these two consortia.
I think I can jump on that one. If I recall from one of the conferences that I went, it was mentioned that, and I've seen so if you have like a veteran that wants to be part of the All of Us program, they have like a different link where they can go and decide to join as a participant. I don't know where the data is going, how is it sorted, how is it presented in the database, but they have been, I've seen flyers in which, okay, you're a veteran and you want to be part of the All of Us, please use this link to register. So that I see. That's as far as I can go about data from the veterans.
Our first presentation after lunch is on tribal data sovereignty and research. And that is going to be from Del Yazzie. Del works as the director / senior epidemiologist for the Navajo Epidemiology Center. He received his MPH from Johns Hopkins Bloomberg School of Public Health, and he was born and raised in Cove, Arizona on the Navajo Nation. His work focuses on leading the Navajo Nation's leading disease surveillance efforts, putting science and data into action, and to help Navajo communities stay healthy.
Thank you, Pam, for the introduction. Hi, everyone. It's good to be here. Thank you for the invitation, and Steve and your team, and thanks for lunch. My name is Del. I'm with our Navajo Epidemiology Center with the Navajo Nation, and my clans are Kintlachitni is my mother clan, which is Red House, and then my father clan is Tkachitni, which is Red Running into Water People clan. And then my maternal grandfather clan is Hashkantzoy, which is the yucca fruit strung out in a line clan. And then my, sorry, it's a long introduction, clans. My paternal grandfather clan is Maidish Gijni, which is Coyote clan, or Coyote Pass clan. So that's who I am. As Pam mentioned, I'm from Cove, Arizona. If you don't know where Cove is, it's over near Shiprock. It's but it's on the Cove is on the Arizona side. So that's where I'm originally from. That's where I grew up. And our program, the Epicenter, is in Window Rock. And that's the image you see there. The window is just up the road from our office. So it's actually a kind of a tribal park. If you've never been there, you can go there and walk around, and you can actually hike behind the window back there. So yeah, nice little spot. It's actually colder there than here. So this morning, I think it was like 2 degrees. So yeah. Yeah, very interesting discussions. Yeah, thanks for inviting me. Genetics is also always an interesting topic and discussion, especially for, as I mentioned earlier, regarding or for tribal nations. I took my ACE inhibitor this morning, so hopefully that'll prolong my life. Dr. Karnes, is that in the database? ACE inhibitor prescription. So anyway, thank you, Nick. Just very quickly, this is my outline of what I'm gonna talk briefly about. Our epicenter, the data sovereignty and our tribal IRB research, program and some examples for doing research on Navajo, collecting some tribal data. I'm going to say a few words about the junk food tax policy that we have in place currently. It's a 2% junk food tax. So when you go to the Navajo Nation, make sure you buy some junk food. So 2% of it will go towards the revenue. So, and that goes back to communities to do health and wellness activities across our nation, or not Navajo Nation. And then cancer, and then some ongoing Navajo genetics policy discussions, and how researchers can help working with at least with Navajo Nation. So Epicenter, founded in 2005, and we always try to translate or mention our translation of epidemiology to Nalka, which is the literal translation is disease tracking. So a lot of our own Navajo people don't know, or usually ask us, what does epidemiology mean? So Nalka is disease tracking, founded in 2005, and you see our mission and vision statements there. And then just a little overall picture here. Our work focuses on the Navajo Nation, the jurisdiction, land, tribal land base on Navajo, and you see there, oh, there. Does this have a pointer? No. Oh, yeah, I see the land base there. Our land goes into 3 states, Arizona, New Mexico, and Utah. And we're one of 574 federally recognized tribes. And we have 5 tribal agencies on Navajo Nation. You see there Western, Central, Fort Defiance, Northern, and Eastern agencies. And then within the Navajo Nation, there are 110 chapters. These are small local governments within the Navajo Nation. Our land base is about the size of West Virginia, 27,000 square miles. There's some population numbers there based on the latest 2020 US Census. We did go up, or our population numbers did increase a little bit. Those who actually live on the nation is about 165,000. Those who live off the nation, 250,000. So we're a little over 400,000 total. And we're pretty rural, 6.3 persons per square mile. No, this is fine. Yeah, thank you. And then one of the main things we do is provide epi support for our tribe. And y'all are in public health, so you know that we collect data, compile and analyze the data, the interpretation, communication, and hopefully put that into action. And just some reports that we update every now and then, mortality and cancer. This is just give you an idea of the data flow for our tribe. We're the epicenter, and we're still trying to make our center like the data hub for all the data that's being collected on Navajo, mainly from the IHS facilities on Navajo, and also from our state partners, state departments of health from Arizona, New Mexico, and Utah, and also CDC. So as you can see, there are a lot of arrows going different places. So the data systems for us is oftentimes is pretty fragmented. There are a lot of data gaps, and that's what we're trying to address currently. So indigenous data sovereignty, like what does that mean? There's you might have heard that phrase before. There are a lot of ongoing discussions about indigenous or tribal data sovereignty for indigenous peoples having the right to govern, the collection, ownership, and the application of the data for the benefit of their own, governance of tribal resources or health and wellness activities for their tribe. So, and a lot of it derives from having the inherent rights to govern their own, peoples, lands, and resources, and really the origins of some of the data is really in the traditions and roles and responsibilities. And there's a lot of cultural knowledge and information, and some of the ceremonies and rituals where a lot of the tribal knowledge and information can come from, and having that sovereignty and the protection to hold that information for tribes. And a lot of it, is like positioned within the human rights, the framework. There's a lot of, there are treaties that are in place for tribal nations across the country through, court cases and other recognitions, et cetera, et cetera. So, and then in the mainstream, we're all, in public health. Oftentimes we think in this fashion when we talk about data. Oftentimes it's statistics, and to use the data for reasoning, discussions and making calculations. But oftentimes for tribes, it's not necessarily the case. It's more, some of it is, as I mentioned, like traditional knowledge. Again, this is just a reiteration of what are indigenous data, data about resources and environments, and then about individuals, and then as a tribe as a whole. So these are some information that tribal nations hold, and they deem it their own, and through their sovereign governance. And now I'm gonna transition to our own Navajo Nation tribal IRB. I just took a quick screenshot of the website here. These are our current IRB members here, and this is a lot of tribal nations look to our Navajo IRB to be the kind of the model, because other tribes are looking to create their own internal tribal IRB processes. And so oftentimes they reach out to us for guidance and technical assistance on how our Navajo tribal IRB came about. And it was established in 1996. So we're approaching a 30-year time frame here. And each of the members, there are 6 of us now, but we're looking to add 3 more. So we're all appointed by different entities on Navajo. See, the 3 of us, the first 3 were appointed by the Navajo Nation President's Office. And then the bottom 3 are appointed by the Navajo Area Indian Health Service. And so there's 6 of us currently, and we're looking for 3 more that are appointed by the Navajo Nation Council. So the appointment of each member come from different Navajo Nation entity. And that's how it's written into the tribal code. Legislation from the tribal council is how the appointees are or should be appointed. And really, this is just another snapshot I took from the website. But, the research that goes on Navajo is really, in partnership with a lot of researchers from different entities and different academic institutions primarily. And mentioning earlier to a friend that currently a lot of the folks who are coming through the IRB are our own Navajo students who are attending academic institutions throughout the country and are looking to conduct their PhD, research dissertation projects, and they come through our IRB to conduct their dissertation research on Navajo. So, which is good to see. And this is just very quickly some phases that if you were to come to do research on Navajo, you come through the Navajo Nation IRB office. And one of the main things, like phase one, one of the main things we look for is community partnership and engagement. So part of your proposal, your application, you have to get approvals from the community that you're going to do research in. Like at the 110 chapters that I mentioned earlier, if you're going to if you're going to be conducting research in one of those chapters or a couple or 10 of them, for example, you have to go to those chapters and present your project to the community members at the meeting, and they'll vote on whether they approve for you to come and do research within their community. Then you go to other like health boards, community organizations, is really the phase one. It has to be part of your application packet, the approvals that you get from these communities. And then tribal program partnership within for example, the Navajo Department of Health. Oftentimes people reach out to us to write a letter of support from the Navajo Epidemiology Center, or maybe our CHER program or health education program within the Navajo Nation Department of Health, or even other health programs on the Navajo Nation is really what we look for as well, that community engagement. And then we do have these screenings. We look at their proposals before the actual meeting as IRB members to make sure all the documents are in place and so forth. And then there are other phases. The PI actually comes to the meeting before we have monthly meetings. They come before the board and they present their proposal, and it gets I've been on the board for like 5 years and we've never disapproved one project. So and the implementation of doing the study on the nation, the data collection, the analyses, and presenting along these phases, you come to the board quarterly and you provide your updates. And when you're finished with your project, the final report and the submission and the transfer of the data to the Navajo Nation, to the IRB office. And then of course, a lot of people write the manuscripts for publications. And this is where we, as board members, look at the manuscripts to make sure that we're approving of what the research work is all about. And now we're really vouching for our own Navajo people to be part of these publications. And we encourage the PIs to involve the Navajo people that they're working with or from the communities that they're working in, and to give them the opportunity to be part of the publications. Is something that we encourage. And then going back to the community where you did the research and providing them update and the outcomes of your research is something we highly encourage. And I was just talking to a couple of people. This year we'll be having our Navajo Nation Research Conference. We usually have it at Twin Arrows. I'm not exactly sure if we're going to have it there this year, but it's usually in October. So all the PIs that are doing research on Navajo are required to come to this conference to present their project. So, and one of the biggest thing is the final data transfer to to the tribe. The PI does not keep the data. That's a part of the agreement. And just one quick example of how, data sovereignty and governance of for a tribal nation's data and information can be a good thing. This is we have a junk food tax policy in place. We call it the Healthy than the Nation Act. And we partnered with a lot of programs, including NAU, to evaluate this health policy. And mainly looking at how much, like I said, 2% tax on a junk food that's purchased on Navajo Nation. How much revenue is generated? It generates about $2 million a year. And that $2 million goes back to the 110 chapters for them to conduct health and wellness activities within their community. So, but 2 million split between 110 chapters is not a whole lot. The average is about $13,000 that a chapter gets. The bigger the chapter, the more they get. So that's how this junk food tax is in place. It was implemented in 2014. Our president at the time was President Shelley, who signed off on this or put it into action. It's the first such policy on a tribal in the U.S. and any tribal nation to put tax on junk foods. And this is how it promotes tribal sovereignty as well as data sovereignty for the benefit of a tribal nation. And a lot of it, required engagement, not just with our tribal communities and stakeholders, but also external partners, such as NAU. I know, Steve, Dr. DeHare, and Pam, you do too. So he's helped us with a lot of the leading the work on this, the guidance and leadership and evaluating our policy, junk food tax policy. And so it was initiated in 2014, but it was set to expire in 2020. So we did all the evaluation work prior to 2020, and it was set to expire in December 2020. And on the last day of that year, our president at the time was President Nez and Vice President Leiser there. They renewed the legislation to keep it going indefinitely, this time with no end date, no sunset clause to it. So currently this is still in place and it's still ongoing. All the stores on Navajo Nation are collecting the 2% tax on junk foods purchased at the stores that are located on the Navajo Nation land jurisdiction. And some of the good things that came from this evaluation work, we engaged, the tribal leadership, and they used our data and the evaluation, all the information for them to be informed, number one, and also to help with the renewal of the policy. And we crafted a lot of communication materials to, disseminate to all the communities across Navajo, even Navajo Nation leadership. Even scientifically, we published 10 peer-reviewed journals. And a lot of these first authors were from NAU students, Navajo NAU students in public health. So Dr. DeHare's students were all first author on these publications. Yeah, student support, Navajo graduate student support. This is all from NAU, 10 NAU's MPH students. So I'm almost done here. This is the cancer also. I just want to share this because this is pretty cool too. This is the first that we know of the first tribal cancer data dashboard. Again, with Dr. DeHare and other team members down there, you see the logos from our cancer registries from Arizona, New Mexico, Utah, and collecting the cancer data for Navajo Nation. And we updated that report last November. And this time we created a dashboard, and this is available on our Navajo Epicenter website. It covers incidence, mortality. You see the tabs up there. Mortality, stage of diagnoses is all a part of this dashboard. And yeah, and some of our own Navajo students are currently writing grants using this grant proposals, using the cancer data to address. One of them is looking at prostate cancer. The other is looking at stomach cancer. And one is a fellow at NIH. And the other one's at Fred Hutch Cancer Center in Seattle. So and then like genetics. I was talking earlier about there are some ongoing discussions about genetic research on Navajo. I think everyone knows maybe like there's currently a moratorium on genetic research on Navajo Nation through the council. There's a hole on it. But there's these two ladies you see down at the bottom, Dr. Nanaba Garrison and Dr. Katrina Tlaw, both Navajo ladies, PhD degree ladies. Nanaba is a professor at UCLA. Katrina is at University of Colorado, and they're both leading this effort, hosting these forums on Navajo. This was last summer. I just copy and pasted their flyer to gather people's opinions about lifting the moratorium a little bit to allow some genetic research to happen for the benefit of the health of the Navajo people is ongoing. And so there's a working group. These are some areas that they're a part of their policy packet. And they have this introduced to the council, Navajo Nation Council. They have a sponsor. Currently, a Navajo Nation Council member is sponsoring this potential legislation. So it'll be introduced here shortly to the entire Navajo Nation Council to continue the discussions. And I'm not exactly sure when, but there will be a vote, I'm sure, at some point by the entire Navajo Nation Council, whether to lift the moratorium to allow some of the genetic research to happen. So maybe this is where the discussions we've all had earlier can be part of it. So. And last, how, good things can come from research and partnering, including, genetic research. Mentioned students, Navajo students, building that capacity to conduct not just research, but just public health in general for our Navajo people. And then publishing and presenting data to the community, tribal government for their own information is something that we, as the Epicenter, try to do. Even beginning with the word epidemiology, as I mentioned earlier, a lot of people don't know what that is all about. A lot of people think it's another like outbreak or like COVID. Every time they hear epidemiology, like, is there another outbreak coming? Anyway, so good things can come from a lot of the discussions and partnerships, collaborations with tribal nations, not just Navajo, but with other tribal nations. So, and that's our contact info, and that's my presentation. Thank you.
Question. In your 5 years being on Navajo IRB, how much growth in the proportion of actually Navajo tribal members coming through with their own projects have you seen? Has there been a change in the past 5 years as far as scholars that are tribal members?
Okay. Yeah, we're starting to see more Navajos coming through the IRB to propose their research project. A lot of them are students in PhD degree programs at various academic institutions coming before us for them to conduct their dissertation research on Navajo. So yeah, we're beginning to see more and more. And also the encouragement to other non-Navajo PIs to give our own Navajo people the opportunity to be part of their research project, and also in the end to also give them the opportunity to be part of a potential manuscript publication. So that's kind of like something we highly encourage to all the PIs coming through the IRB. So yeah.
Okay, while Nick gets us set up tech-wise, I will go ahead and introduce our next speaker from NAU. So thank you for being here. David Faguy is a special advisor with the Office of the Vice President for Research at Northern Arizona University. He retired as the Associate VP for Research Compliance from NAU in 2023. He acts as a part-time consultant for different companies in biodefense and regulatory matters. He has a PhD in microbiology and immunology and decades of experience in universities, public health, and the military contracting. And thank you for coming and being willing to speak on data privacy and security for us.
Well, thank you for inviting me, and I hope this will be a useful presentation. Please go ahead and interrupt if you have questions or comments or concerns. I'd like this to be kind of an interactive process. I think that's the best way to exchange information. I didn't know exactly what to talk about today. This is a very broad realm, data privacy and security, but I wanted to give you a background in some of the principles and give you some background on more of the administrative side. That was my role in data privacy and security here at NAU and in other roles. And so I wanted to give you some of the background and then talk about some of the principles behind that. So one of the biggest administrative structures for health information is HIPAA. And I hope we're all familiar with what HIPAA protects and what researchers can access and use. There are ethical and legal constraints around using health data. And this is particularly important for data covered under HIPAA. So HIPAA data covers a wide variety of data and information. And you can see it all up there. Just to get some interaction going, is all of us HIPAA data? Does anyone think it's HIPAA data? Certainly has patient demographics, medical records, lab results. Is it covered under HIPAA? HIPAA is a law, right?
So because there's not names, does that, along with the data, does that preclude it from being covered?
No.
Oh, okay.
It doesn't.
Okay.
I mean, names are one thing that is identifiable, but there's a lot of other identifiables. So that alone does not exclude it from HIPAA. What do you think? Is all of us HIPAA data? First of all, has anyone participated in all of us? I know you have. And do you remember one of the things you signed? It was a HIPAA waiver. You waived your rights for your data to be covered under HIPAA. And so that's why all of us is in HIPAA. But it's good to keep that in mind, that these structures and administrative requirements, a lot of them have been taken care of by the All of Us program, and that's one of the reasons it makes it so valuable. So just keep that in mind. So you mentioned de-identified data. And that's another way for health information not to be covered under the HIPAA law. What's de-identified data? How does the law state that it can't be used to re-identify? It has a number of possible identifiers that have to be removed. So there's some requirements for removal of a lot of data elements. And that includes all of these. If you look at all of these data, and one of the things that I find in helping NAU researchers do human research is that a lot of the information you want for your research is in these data elements. And so de-identified data has limited use. We'll just put it that way. Especially when you get things like dates. If you can't use dates, that becomes really problematic for any kind of progression. So de-identified is anonymous under HIPAA and publicly releasable. You can release it to anyone for any reason. So it's free. And you can see all of the different identifiers. Another type of health research data that gets confused with de-identified data a lot, so I want to talk a little bit about this, are called limited data sets. So under HIPAA, a healthcare entity like Northern Arizona Healthcare can share data without the patient's permission in a limited data set for specific research purposes. So it's not de-identified, it's not anonymous. Those are not words that apply to limited data sets, but it does have direct identifiers removed. But you still have to treat it as private health information, PHI. It's still PHI. A lot of times health researchers get confused between de-identified and a limited data set. And so you mentioned just removing the name doesn't make it de-identified because you can still identify it or re-identify it. So I talked, that's how we regulate health data under HIPAA. I didn't have it on the slide, or I forgot to mention it. A limited data set requires a data use agreement that stipulates exactly what you'll use the data for and a term and other conditions. So a healthcare entity can share health data with a researcher under a limited data set for a specific use. That's how that works. That's the HIPAA law. There are lots of other laws that govern data, export control laws, controlled unclassified information, FERPA. There's all kinds of rules, regulation, laws around data. And unfortunately, I'm more familiar than I really want to be with most of those. And they all have specific controls and ways of ensuring that it doesn't get out. I just wanted to put a few of these up to describe that there are legal consequences both to the institution and sometimes even to the individual, depending on the nature of it, for exposure of information that shouldn't have been exposed. Most of these are health-related, unencrypted laptops stolen from a car, settled for $4 million, and then there's a bunch of other ones. There is an Office for Civil Rights in I think it's the Office of Inspector General for NIH, whose sole job is to go after cases like this, to ensure that people's rights to their health information are protected. That's just to scare researchers a little bit. And also to try and push you to see why the All of Us system can be really useful, because that administrative load is taken off of the institution and the researcher a little bit, and it makes it a lot easier. Okay, I'm going to talk a little bit about data classification at NAU. This applies, maybe with some differences in words or a level or two, to most institutions. Most institutions will have 4 or so levels of data classification. Level 1 is public. What would public information be in health research that we're talking? What health research information is public? Published studies, certainly, anything published is public. De-identified data that I talked about. There's also a lot of data publicly available. Data on the All of Us program in the public browser is publicly available. You can use it for any research. So there's lots of publicly available data out there. Census data, all kinds of things. Level 2 is internal. That really doesn't apply unless you're a healthcare entity and then you have your own procedures. At NAU, then we have a level 3 sensitive data. And these are PIIs, unpublished research data, proprietary or NDA covered data. And then level 4 is highly sensitive. And this is where we get into human research data, private information or PHI or other types of regulated information. I noticed on my NAU email system, they now have the ability to classify emails based on these 4. And that's where that comes from. One of my reasons for bringing up CUI, controlled unclassified information, this is it is a new federal standard for non-public federal information. And right now, it only applies to the Department of Defense information, but it's going to be expanded to all federal non-public information. And so people from all areas of the university and healthcare are going to be dealing with federal information that's non-public. And we're going to have to use these classifications. I just kind of put this up for reference to show you what kind of different ways of handling information is required for the different levels. So access controls, you can leave it open on a website. You can share it publicly. But when we get into sensitive and highly sensitive, then we need specific methods and protocols to ensure the security of that data. One of the simplest ones that we don't do, I don't think I have it on my personal laptop, is whole disk encryption. So all of our laptops have the ability to use BitLocker for PCs, and I forget what the Apple version is called, but it can essentially encrypt everything that's on your laptop. So no one can, if someone steals it, they can't get access to the data. That's a very simple one to do, and it's required for these levels of sensitive data, as well as authentication and things like that. For physical security, for the highly sensitive things, actual entry must be logged. So if you have a room with paper files, you have to log who goes in and out. And that's at the highest level. And you can see some of those other handling things. Does anybody have any questions on that? I just wanted to give you an idea of what's required. And also to lead into that discussion of the All of Us researchers workbench. Because what that is, that takes care of all of these controls for you. They handle the access controls. They handle the how the data is stored and maintained. Okay, we've seen this before, how All of Us is important in nurturing partnerships and delivering a very robust data set to catalyze the development and enhancement of research across the country. And this is, I think, something to keep in mind as we're talking about all these data securities, that ultimately the goal is an ecosystem of communities, researchers, and funders. We've talked a little bit about the public data browser, the public tier. It's aggregate data with no identifiers and no ability to cross-reference. So you can't ask how many people in Arizona have had a mammogram. The registered tier is a curated data set, and it contains individual level data. And the controlled tier adds genomic data and other data. Most, as you said, most researchers are going to want access to the controlled data. The registered tier, one of the big differences is it only has state level data. And so that really can limit the utility if you're doing any kind of geolocation. So the controlled tier is more commonly used. Are any of these HIPAA data? I asked that before. No, they're not covered by HIPAA because we signed a HIPAA waiver when we're a participant. Are any of these private health information? Yes. So I'm kind of emphasizing that there can be these differences. And again, one of the reasons that all of us is very powerful is it takes having to worry about all of those, quite frankly, detailed semantics around the legalese away from the researcher and the institution and towards the program. One of the other things I'll mention at this point that I think was brought up in the talk earlier on using undergraduates in research. One of the big advantages of using this All of Us data set for undergraduate work is that it does not require IRB approval at your institution. And for those of you who've tried to have undergraduates do human research, it can be problematic because of the timeframes involved in getting IRB approval. It's much easier on the advisor, the student, and the IRB if it's an All of Us data set. So just to show you some ideas of what's in the data set, there are 25,000 odd conditions listed there. I don't think I could think of 1,000 conditions. Well, maybe I could. I probably have 500 of them, so I probably could. And then 30,000 drug exposures. So there's a lot of data in there available for manipulation and in health research. One of the caveats that I'll throw out there and that's important, and this goes back to the ethical conduct of research. One of the principles of the All of Us program, as well as IRB approval and other approvals, is that the data is used only for the purposes requested or applied for. And so for the All of Us, if you change your hypothesis that you're trying to seek to prove or disprove, you have to do a new research narrative. I forget the exact word they call it, but workspace description. And the same thing with an IRB study. You would, if you change your methodology, if you change your purpose, you have to do a new or amended IRB application. The same thing with the All of Us program. And that's really important. And that prevents researchers from being able to go in and fish too much. And that's to improve our confidence that the data is secure and is used for appropriate purposes, rather than being available for inappropriate purposes. Do we have any questions on that, or anybody want to bring up anything for discussion around some of this data privacy? No?
Sure, Dave. I'll play ball here. Well, one of the things also on the list of 18 HIPAA identifiers at the bottom is a little paragraph that says, even if you take all this stuff out, there might be left information that when combined can identify somebody.
Yes, and that's one of the other principles of health research in general, and All of Us in particular, is you are required to sign and assert that you will never try and re-identify any of the data. You'll never try and get the identity. Along with that, if you want to combine it with other identifiable information, even the limited data sets, for example, from another source or things like that, the All of Us program wants to review that, and they have a review board that will look at that and say, okay, how does that increase or change the chances that it could be inadvertently re-identified or is able to be re-identified? So combining data in All of Us with outside data is something that has to be carefully considered and approved, which is a good point.
Okay, thanks.
And the whole point, again, being that we don't create a situation where participants don't have confidence that their information will be used in an identifiable way.
And my recollection is also that if you do accidentally re-identify somebody, you do need to report that to them. So they have a kind of a policy in place in case it does happen. Do you know of any instances? I mean, I don't know how much they would report that, but I'm curious.
Yeah, I mean, certainly not at NAU. I mean, I'm the administrator for this at NAU, and we have not had that. And I think that would be, it would be kind of difficult to inadvertently do that with the way the data is structured. Having said that, and you mentioned that genomic data is obviously identifiable at some level, and so that's one of the reasons why the All of Us program is taking very great pains to educate and train researchers and make sure that they're aware of potential ways of re-identifying that and combining it. So here's some numbers from the surveys. And earlier we had a question on incarcerated people. And I haven't looked at all of the questions. I don't think that's a direct question. But a lot of the questions in the social behavioral or social determinants of health revolve around crime in the neighborhood. And so you could certainly construct a research program that looked at individuals who live in neighborhoods with high crime and are maybe more likely to be incarcerated than, and some of the health determinants. And so I think that's, I think like any data set, there might be some effort in crafting a research strategy to get to your question with the information available. But the number of respondents it will be a lot of work to get thousands of respondents to a survey doing your own research. So we haven't talked much about the registered tier, but just to point out some of the things that may be removed that are, and some of these are added back to the controlled tier and some aren't. But things like geolocation data, race and ethnicity subgroups, active military status, death causes, and this is the reason why the registered tier is not as valuable to researchers as the controlled tier. But it still may be valuable depending on your research questions, and it has less controls, especially on combining outside data. And so it might be appropriate depending on your research designs. Okay, so that's all the slides I have. Do we have any questions or anything we want to talk about relating to the data and security?
No, but I do have a question on your last slide. I saw that dates are shifted backward by a random number between 1 and 365. Why and how? Or why? And
So
like, does that change the value of the data?
What it will do is it removes it from being a direct identifier. So if I saw a car accident last week and I saw the ambulance take him to NIH and I had access to the data and I picked out that date, that could be re-identified with relatively easily available data or even a newspaper article about an accident. And that's why de-identified data doesn't have dates. And so in this registered tier, they've attempted to transform the data so it can be combined with other data without worrying about re-identification. And so that's why they do it. And what that means is if you're looking at a research study that has some kind of time progression, this happened after this, anything less than 365 days will be randomized. So not useful. But if you're looking at 2 or 3 years, that might still be useful. If you're looking at ages, doesn't matter if I'm 25 or 24. I'm not, by the way. But, you get the idea. That randomization, that data transformation is a common technique in large data sets to prevent re-identification and therefore make it more usable for other purposes.
Thank you.
I just have a comment. With my presentation about tribal data sovereignty and all, oftentimes we talk big about that as tribal people. When it comes to data and research and data ownership, but oftentimes a lot of tribes, including us at the epicenter, that we lack the infrastructure to house information, house data that's in a secured environment, following, the HIPAA guidelines and we're trying to build this currently a cloud-based computing system with a contractor that has we're actually just piggybacking off this contractors like insurance and HIPAA compliancy, et cetera, to help us begin to store the data that we collect. And it's quite expensive. And so, and a lot of tribes we don't have the infrastructure oftentimes to comply with, HIPAA law. So it's a big deal. And we're learning the whole infrastructure for it and how expensive it is, the software and the hardware and blah, blah, blah. So, yeah, so that's something for us really as tribal nations to consider and think about. Anyway, so that's my comment.
No, I think that's a great point, and it's something I deal with, and one of the reasons NAU hired me back, I think, at part-time, is with NAU, which is a very well-resourced institution. We have trouble meeting certain security requirements and are looking at some of the same solutions for offsite providers, cloud providers, and it can get expensive and problematic, and I've been pushing NAU to think about long-term solutions for creating a structure on campus where there is a secure level that's integrated but also separate. And it's not an easy problem. It's a very hard problem. One of my other roles is with the Department of Defense, and I'm a defense contractor, and they've had rules for 15 or 20 years requiring some of these data protections to be in place. And only now has the systems evolved to the point where they're universal. And so it's a long-term prospect, and I think it's going to be essentially universal, that we're going to have more secure data enclaves and repositories. But it's expensive.
So just going to ask a question while we're getting Dr. Karnes' presentation queued up here. But because the data in all of us are de-identified, somebody might self-report, hey, I'm a tribal member, that sort of thing. That data is pulled from that, I assume. And same thing, there will be other protected classifications, pregnant women, potential, folks that have been, incarcerated, that sort of thing, right? So there are protections placed once again, which is where all of us makes it safe for us to do the data, and we'd have to look hard to find some of those.
Yeah, I think there are a couple of points to that. I think you're right that they will remove those problematic survey results.
Mm-hmm.
But I think also, and this is particular for tribal sovereignty and Native Americans, is that the concern is not just for the individual, but the tribe. And so I think there's some additional layers of protection that may mean all of us, at least in this current data set, does not have that information. all of us have a tribal consultation policy, and they have a summary of the tribal engagement process. And one of the things, one of their core tenets is that especially with respect to the biological samples, is that tribal members and anyone can request what happens to those when they die. And in fact, they have not processed the biological samples of anyone who identifies as a Native American, Alaska Native, because of the concerns around genetics in tribal communities.
Yeah, thank you.
Okay, thanks for that. Now that we've learned everything we should not do with the data, and there's a couple of nuances too. There's a couple rules. There's lots of rules that weren't mentioned from a privacy protection perspective. For instance, if you're publishing data, you're not allowed to refer to Ns or sample sizes less than 20. If you're referring to a participant group that's small, the risk of re-identification increases, right? And this comes up a lot, especially when we talk about rare variants and genomics. Another thing you're not allowed to do is download row-level data. You get these things called egress alerts, where your access is completely shut off. And that typically, sometimes it happens when you're doing very mundane things and you're just processing a lot of data. But the intention is if it detects that you're downloading large amounts of data from the workspace, then it will shut off your access. And then there's a way to anticipate this and to avoid it by doing like a pre-approval. But that's a part of this cloud computing environment too. And that, again, this is a balance between research productivity where, yeah, this gets annoying and it's difficult to navigate and researchers lose time and resources as a result, but it helps protect the data. And so you're not allowed to download row-level data from either the controlled or the registered tier. Even just an ID and a sex in 2 individuals, that's row-level data, and you have to be aware of that. That's one of their highest level of infractions, and they're likely to restrict access or cancel your access if they find out you're doing it. And it can be done accidentally too. You have to keep that in mind. So the workspace descriptions that I talked about, you work within workspaces, and you can actually print out those workspaces, which is the code that you're using to analyze the data. That's not row-level data. There's nothing wrong with that. But often that code has snippets or previews of the rows. And so you may come off with a PDF that has, a snippet of 10 of the first 10 rows within your data frame, and that's technically a violation of the DURA, right? So you have to be aware and be able to suppress those, and that was one of the early problems that we had in working with this data, but it's more or less, started to be resolved. So it is complicated, and the regulations and the environment are always evolving. But I want to focus this talk a little bit more on diversity, specifically genomic diversity, and some of the opportunities that the data set affords. Talking a little bit about some of the preliminary data and some of the data that we've disseminated through preprint articles at this time, just out of my lab primarily. And I think it's illustrative of what you can do and some of the issues with working with EHR data in this genomics environment. As I alluded to before, the vast majority of genetic information that we have are from individuals of European ancestry, right? So over 80%, and this is well known. There are lots of reasons for this, but when you consider that, European ancestry individuals only make up 12% of the world's population, and they're relatively homogeneous from a genetic perspective, you're just not looking at a lot of variability. We've made great strides in terms of genomic discoveries in the European ancestry group, but we're kind of scraping the bottom of the barrel here. We need to look into other ancestry groups if we're going to make discoveries. And you can see here how just in very many groups, especially groups like American Indians, you have a very poor representation of the genetic diversity in the resources that we currently have that researchers can access. This is a problem not just based on representation. This is a scientific problem, okay? When all of the variability is outside of the group that you're looking in, you're limited in terms of the discoveries that you're gonna make. PCSK9 inhibitors is a drug class used to treat hypercholesterolemia. This was discovered, this PCSK9 gene, because they did the same study looking at LDL, genetic influences of LDL in an African-American population, not in a white population, right? So it was the same study, same approach, just a different population. In people of European ancestry, they don't have PCSK9 variants. It's just a low frequency. And so by looking outside of that group, they found the signal. They were able to associate this gene function with LDL cholesterol processing and signaling, and a new drug class comes out, which is usable in anybody, any ancestry individual. It's just that there wasn't the variability in that initial group. We weren't able to see it. And so just think about all the discoveries that are just waiting to be made if we can just make this a more diverse cohort. The data is borne up here because you can see, although you have 80% of the individuals, there is a disproportionate number of associations that you find, a disproportionate number of discoveries that you find when you look outside of individuals of European ancestry. And I also want to make a distinction here between ancestry and race and ethnicity. So race ethnicity is a sociocultural construct. It's something that you self-report and that you self-identify with. Ancestry is genomics. I can objectively look in your DNA and tell you where your ancestry, what your ancestry is, where you come from, who your ancestors are, your relatedness between individuals, right? And these things are often conflated, which is problematic. And they've been conflated in publications out of all of us. And just to be forthright, this is an example of a study, a very high profile study coming out of all of us describing the genomic data, in which they were comparing UMAP diagrams, which is essentially ancestry, to self-reported race and ethnicity without any disclaimers around, hey, ancestry is not the same as race and ethnicity. These are different things. Race ethnicity is typically based on skin color or other sort of tribal characteristics, whereas ancestry is based on DNA, right? And this conflation has been problematic for historically. And even, even to this day, the mistake still keeps getting made, even by people with experience in all of us. You've seen this multiple times. One comment that was made was around the number of conditions, and like these are 23,000 conditions and 28,000 drug exposures. Keep in mind, there aren't 28,000 different drugs in that list. All of those discrete variables are, warfarin 5 milligrams, warfarin 2.5 milligrams, warfarin 1 milligram, right? The different dosages, the different dosage forms that you get. Amlodipine can be given, or nifedipine, say, can be given orally or can be given IV. The different dosage forms are represented in these different types of drug exposures. And so there's a lot of data cleaning that is involved. You have to go in, you have to see what's there, what makes sense in terms of, combining this data. Do we ignore the topical formulations of a certain drug because they don't get absorbed systemically? That's typically one of the questions that you need to ask. Because hydrocortisone can be given orally, or it can be given as a topical in the skin. And if you're looking at, say, like liver adverse reactions, maybe you're ignoring the kind that you can that you put on topically. You've seen this before, and this was reviewed in the last presentation much better than what I can do. One thing I'll add is when all the data is stored centrally, that typically provides benefits in terms of the total amount of storage, right? The data is stored in this one place. If everybody had a copy of the data, it'd be taking up room at all these different institutions, and then the computational resources would be increased in order to navigate the data. However, there are drawbacks. Now you are subject to the administrative controls and the infrastructure that all of us has built. You have no choice. You have to use that. You can't use your local pipeline. You can't use your local high performance computing system. Your institution may have spent, hundreds of millions on it. You can't use it, not for this data, right? It has to be on this cloud computing infrastructure. And so if they haven't installed a version of the program that you want to use, you got to ask them to install it, just like you would at the HPC, for your administrative controls. But they're serving a whole nation, right? And now it's international access as well. So that administrative control, the nuanced control piece is not as, let's say, user-friendly. That being said, there's a number of useful tools. I mentioned workspaces. That's really how each project is intended to be represented. Each project is a workspace. Within a workspace, you have multiple notebooks. These are like different analyses associated with the same research project. Dataset builders, you have cohort builders. These are point and click tools that you can use. Let's say you're not as familiar with R or Python, you're not going at it from a command line interface kind of approach. You can click and select, I only want people above this age, or I only want people with genomic data. And you can create that cohort. And what it's doing is it's creating a SQL code that it pulls into your notebook, and then it executes it, right? And so it creates this cohort. It does that work for you, but there's not a tool, a sort of analysis builder tool, right? People typically will get in, they'll build their cohort because they know what they're looking for, and then they get stuck because they don't have the R or Python programming experience to be able to run a logistic regression or even a chi-square test within this computational environment. And so that's typically where the analytic expertise issues come in. So the advantages of the researcher workbench, which is what we're talking about, that's the only way to access this data. That is this Google Cloud Compute driven engine, computational cloud computing engine. So it's powerful, right? There's all kinds of GPUs. It's a little expensive, right? Especially when we have all this big data. But you do get free credits. You get $300 in free credits each time you sign up. So every new user gets $300 in free credits. And if you're not using this for large scale genomic analysis, that goes pretty far. I mean, you can use that for a year or more, depending on how much data you're interested in utilizing. They provide a number of resources in terms of genomic data sets. They have featured workspaces, right? So if you're interested in getting your feet wet, this is one of the first places I suggest going on the workbench, because if you're doing a genome-wide association study or a phenome-wide association study, or you're applying a methodology that's been used before, a featured workspace will show you exactly how to do that within the workbench. Now, it may not be the phenotype that you're interested in, but you can apply the analytic pipeline to the problem that you're trying to address. The other nice thing about this, another advantage, is everybody's got the same resources to work with, right? And so there's a level playing field from that perspective. It's not like, the Broad Institute can take all of their computational power and then, solve this issue before anybody else can. There is a fairly a level playing field. And then the DRC, the Data and Research Center, does provide support. They have ticketing system. They will debug, they will give advice, they will tell you whether resources are actually available. But we've got limitations here too. I mentioned the learning curves. You really do have to have some proficiency in cloud computing, in R or Python. If you're doing large-scale analyses, especially large-scale genomic analyses, these have a tendency to run up bills in terms of the computational and data storage costs. it's a new paradigm, right? I think most people in bioinformatics are used to using their local HPC, not really paying for it, not paying for the data, not paying for the computation, and using their own pipelines that they've developed. And they can take their pipeline and they reuse it for this project and this project, but those pipelines don't necessarily work on the workbench. You have to use workbench specific pipelines, and every analysis you run has a cost incurred. Every data set that you create and you store in your workspace has a monthly cost that you're incurring, right? So you have to consider that, and it's a very different thought process than the old sort of homegrown HPC approach. I mentioned in my prior presentation this Venn diagram, right? So remember, the more sources of data you're taking and the fewer data points for those sources is going to affect your overall N, right? So even though we have 245,000 genome sequences, when you start combining that with, say, electronic health records, you know, that drops the total down to 206,000, right? So you have to respect this union of these different data types and know that if you're going to incorporate, say, the social determinants of health survey, in addition to genomics, because of the low response rate, that's going to bring your sample size down substantially, okay? And so you just have to recognize that. From a scientific perspective, obviously the diversity is there. Keep in mind, it's still over 50% people of European ancestry, but it's the most diverse genomic resource that we have currently. There's all kinds of data. You are likely to be able to find some data related to your phenotype of interest, just because of the different aspects of data, combining genetic data with the participant provided and social determinants of health, it can be very powerful. There's new data released regularly. So every year you get new EHR data. And one of the really nice things, and this again applies to the sort of offset, that all of us is doing all of the regulatory stuff for you. It is so easy to collaborate with people at different institutions. It is simply a matter of taking their registered username and adding it to your workspace. That's all you need to do, right? And if you think about the DUA kind of situation, when you have other clinical studies or even transferring de-identified data sets between institutions can be a large regulatory hurdle. This makes it very easy, and that really, it helps in terms of the collaborative nature of this environment. We've mentioned a number of these limitations, the data cleaning, there's missingness. I mean, this is sort of, you know, how electronic health records data works. We have yet to really understand, I think, the implications of disparate clinical and billing practices across sites. There's unclear data release times, right? So if you guys know when the next data release is coming, you let me know, because I don't. And what it's going to look like is also sort of a black box. It's like, what are they going to provide this time? I don't really know. They don't really provide documentation on that. You just kind of have to, oh, look, there's a new data source. Let me root around in there for a month or two and figure out what's available this time. And so that can be frustrating as well. This is that data I was talking about with respect to site. So you can see, you know, there are 48 sites represented here. But there's a lot of people that don't have site represented, right? Presumably because there's too few participants recruited from that site, and this is a privacy methodology thing. So you could try to adjust for this, but there's 48 different sites, right? I mean, if you're doing a logistic regression model, then that's a lot of variables that you're needing to adjust for just to try and consider disparate billing practices across these different sites. I also mentioned the EHR length. So this is within a health system, your first index date to your last index date, right? And you can see that for the almost 25% of the people in the current version of the data, it's less than a year, right? So you're looking at a large portion of people who are just coming in, being seen temporarily, and not really getting regular care there. And so oftentimes when we are investigating this data, we'll set that cutoff at 1 year, and we'll say, you know what, this depends on, you know, what you're looking at. If you're looking at, you know, car accidents, or you're looking at instances of live birth, then maybe you don't want to do that, because those things, you know, that's something that someone might come to a major medical center to do. But if you're looking at chronic disease, we often will set a cutoff at a 1 year and say, all right, I'm just going to ignore those folks because they're not being consistently seen at this health system. One of the things I often bring up is around the diversity. As I mentioned, over 80% of our data is in Europeans or individuals of European ancestry. There's been a lot of efforts to get representative populations across the globe, but most of our tools are still catered towards this European ancestry group. It was developed and validated in this group. And so we are often wondering how amenable these are to non-European ancestry individuals. And here's an example. So this is a published article from our lab where essentially we were looking at ABO blood groups. And you know, oftentimes researchers use genetics to determine what these ABO blood groups are. And there's this preconceived notion that there's these 2 SNPs that always can tell your ABO blood group. Well, that turns out to be more or less true if you're of European ancestry or if you're of East Asian ancestry. But if you're of African ancestry, that approach can be incorrect more than 50% of the time, right? And so this isn't as clinically relevant. This is more on the research side. But the linkage between these mutations and the actual mutations they're trying to characterize is different across these different populations. So we have to be cognizant of that. One of the things we do a lot in our lab are phenome-wide association studies. And so what this is we'll take a genetic variant, we'll look across all of the ICD-9 and 10 codes in the electronic health record, and then we'll see which ICD-9 and 10 codes associate with that variant. And so one of the things that we've done is look at HLA alleles. This is what's used for solid organ transplantation or bone marrow transplantation. This is an estimate of the cost. Like, if you're using a computationally inefficient program, then trying to launch it on 250,000 individuals, like this was our price tag to do this. We didn't actually do this, all right? Because we saw this and we're like, oh, geez, this is awfully risky. So, you know, this is $250,000, $1 per sample almost, to get the data that we wanted out of the genome. And so that's another thing to think about, is computational efficiency is now not just about time, it's about money. It's about how much you're going to spend on a per sample basis to get the data that you want. And so it becomes much more relevant when there's actual money tied to this. So there were some questions about Alzheimer's dementia earlier. We've also done this with ApoE. So this should be interesting. So we used the variants in ApoE to determine ApoE diplotypes. So E4, E3, E2. And we looked at how these ApoE diplotypes associated across the EHR. All right, so what we got here is on the x-axis, you'll see different systems, different disciplines. This is categorizations of these diagnostic codes. So it's everything. It's type 2 diabetes, it's cystic fibrosis, it's anything that has an ICD-9 or 10 code and more. And then you can see on the y-axis is the strength of the association based on the p-values. So that's a 1 × 10 to the negative 120 p-value. Those are the kinds of p-values you get when you have these kinds of sample sizes. But you can see here we did reproduce the association with dementias down on the lower right. We reproduced the association with hyperlipidemia, which is going to be much more common and was much better represented. And then there was some, you know, hypothesis generating lower tier associations, including one with non-alcoholic fatty liver disease that other teams have seen. So that's another replication. But you can start to see, how you can look across these different groups. And we've done this, this is just a different representation of the data where you can actually look at the different effect sizes as well. You can look at the odds ratios and not just the p-values. And so you could see that, hyperlipidemia, very high from a p-value perspective, but the odds ratio is not that high. For Alzheimer's, on the other hand, the odds ratio is much higher. And even a 1.55, which is what we saw with Alzheimer's, is lower than what you would expect in a prospectively controlled Alzheimer's disease cohort that had better phenotyping. But some interesting things you can do with this. You can look across biological sets. You can see whether there are differential risks related to ApoE across these different groups. And one of the things we saw was in hyperlipidemia, there was a much greater effect of ApoE in females than there was in males. And it makes sense if you think about the fact that, males typically have greater environmental risk factors for that hyperlipidemia. But we could also do this with ancestry. Well, here are some of the, this is the basic data for hyperlipidemia. And you can see also that we did not find any differential risk across males and females for the Alzheimer's disease. But you can also do this across ancestry, right? Now, many of these ancestry groups have really low sample sizes, right? So you have to take this in context, as you're really not going to see many of these strong associations in some of the lower sample size groups. But you can start to look across these different groups and see, all right, so what is the odds ratio for ApoE? How does it change across these different ancestry groups? Is that due to something inherently genetic? Is it biological? Or is that due to social determinants of health and differences in access to care, or differences in socioeconomic status or education level? That's something that you can start to address with this data because we have those other data. Here's an interesting, very early on, this data is outdated, but this is a FEWAS of LDL levels. So all we're looking at is how does an LDL level associate with a disease? Now, what we're seeing here, this 42721, that's like myocardial infarction, but the triangle's going down. So what we saw was that actually high LDL was protective against MI, against heart attack. Like, well, there's something horribly wrong with this data, right? Because we know that's not true. But thinking about the dates, thinking about EHR data, thinking about drug treatment, we do have drugs that dramatically lower our LDL. So statin drugs is the highest among them. Right? And when we did this one, we were just looking at the last LDL that got measured in a patient. So the most recent LDL, right? The follow-up analysis was when we said, okay, let's take a pre-treatment LDL. Let's take the LDL before they were given a statin. And then, we saw an increased risk, complete opposite association, right? Because if you have an MI, you're going to be aggressively treated with a statin. If you have high LDL, you're going to be aggressively treated with a statin, and that's ultimately going to reduce your MI risk. We do have a researchers collective at University of Arizona. We're happy to help teams sort of navigate the workbench and to, especially if they're trying to address computational issues with genomic data. And we have a core that you can email me, karnes@arizona.edu, if you're interested in taking advantage of some of those opportunities. We provide seed grants and driver projects to institutional teams that want to use the data. This is part of the research engagement infrastructure that Susan was talking about earlier. We also have Data Fellows training program. So we have an active application open. The submission deadline is later in February. This is a 6-month training program for workbench research. So we train fellows through a genomic, well, it doesn't have to be genomic, through a mentored research project and give them all the skills or most of the skills that they need to get started on the researcher workbench and trying to remove some of those computational barriers. Another opportunity is the Biomedical Researchers Faculty Summit. This is coming up. I encourage you to take a look at this. This is through Baylor College of Medicine, yet another researcher engagement partner. So if you are interested, you're not alone, right? There's researcher engagement partners that are funded to remove some of these barriers and help train individuals in how to actually do research on the workbench. This is my lab. I want to acknowledge all of them, and I want to acknowledge our funding as well. And hopefully this has been informative, and happy to answer any questions that you might have. Thank you.
Okay. Dr. Karnes, I wanted to thank you for being our resident expert today and for fielding so many questions. I really appreciate it. I've learned so much today. I hope that all of you have also maybe met other colleagues you might be interested in collaborating with, or have gotten some questions answered.
We'd also like to mention that all the resources and a copy of this presentation will be available through the CHER link from the CHER website. So feel free to share it or reference it anytime, as well as contact information from our amazing speakers today. Thank you.
Steve, was there anything else that you wanted to say to wrap up?
I think on this one, just once again, round of applause for our speakers. Thank you to Pam for organizing and coordinating this day, to Nick and Cindy as well. So, hey, thank you all. Travel safe. Enjoy the weekend. And please keep your eyes out for our next conferences. We'd love to have you attend. So thank you again for coming. And if you have any suggestions or recommendations, put them in the survey or let us know. Have a great weekend.